and good morning, everyone. I've been asked to talk about the diagnosis and management of polycystic ovary syndrome. As you know, polycystic ovary syndrome is your bread and butter stuff in endocrinology. You see it all the time. It is easy, or sometimes it's not too easy. So what I will do is, I will go in this session, I will go through the diagnosis, especially the diagnostic criteria, what tests to do, differential diagnosis, to consider some specific situations like adolescence, and also we'll touch upon the management. So I have structured around 2 cases to aid the discussion. And there are also 3 or 4 questions, interactive questions. There's no trick questions, so please feel free to participate. So why bother? Why is this? Why PCOS is important? The PCOS is the most common endocrine abnormality in reproductive age group women. Around 5 to 10% of women have polycystic ovary syndrome. And it's not only common, it also causes problems. It's the most common cause of subfertility and ovulatory infertility in women. And it not only causes infertility, it's got other far-reaching health implications, general health implications, such as increased risk of type 2 diabetes and gestational diabetes. So it is common and causes problems. So that's why PCOS is important. Without much further ado, I'll go straight to a case. So you got a referral letter, you're an endocrine clinic, and you got a referral letter from your GP. It is not that detailed. It says that this lady has got irregular periods. She's concerned that she may have polycystic ovary syndrome. Please do the needful. So you saw in the clinic, you took a detailed history. So she's 24-year-old woman. She had menarche at the age of 13 years. She has irregular periods since then, always irregular, and frequency lasts around 1 to 3 months, and the last period was 3 months ago. But she does not have any complaints of hirsutism or acne or male type. So she just has irregular periods. She's overweight. There's no hirsutism when you examined, and the patient didn't complain of it. And there's no clinical stigmata of Cushing's disease or acromegaly. And the GP has done the prolactin, FSH, and TSH, and they were all normal. So the question by the patient is, what is wrong with me, doctor? That's the question. So just what you call an interactive question. There's no trick question. It's just straightforward. So with prednisolone, ovarian insufficiency, hypothalamic amenorrhea, PCOS, atypical congenital reproductive uterine polyp. Yeah. So the answer here is polycystic ovary syndrome. Is some of you commented upon hypothalamic amenorrhea and prednisolone ovarian insufficiency. So this is a study done 30 years ago, and a lot of people have replicated it afterwards. Around 80% of women who presented with this irregular periods or oligomenorrhea, they have polycystic ovary syndrome. So if you sit in the clinic and see a woman with irregular periods, and you didn't take any more history, you didn't do any examination, or you didn't do any test, if you simply say you got polycystic ovary syndrome, 9 out of 10 times you'll be correct. As an endocrinologist, your job is to find out or to exclude the rest. So it's the most of the women with irregular periods have got polycystic ovary syndrome. So I would like to emphasize 2 or 3 points here. Some of you mentioned about hypothalamic amenorrhea and prednisolone ovarian insufficiency. The main thing is polycystic ovary syndrome is not a hypogonadal state. It's a eugonadal state. They'll be well estrogenize. The estrogen will be normal. Compared to hypothalamic amenorrhea or prednisolone ovarian insufficiency, it's a state of hypogonadism. The estradiol will be low if you measure it, or they won't be estrogenized, and they will have raised or low gonadotropins depending on whether it is hypoc or hypergonadotropic hypogonadism. So the first point is PCOS is a eugonadal state. And the second point I would like to emphasize is there is irregular cycles and there are irregular cycles. So what is considered to be a regular cycle? There is something called gynecological maturity. That means if women take up to a girl will take up to 8 years since the menarche to reach full reproductive maturity. Till 8 years, the periods could be irregular. So irregular periods could be normal in the first year post-menarche. That is normal. And the periods can last up to 21 to 14 days. The cycle can last up to 21 to 14 days, 1 to 3 years after menarche. And after 3 years post-menarche, it can range up to 21 to 35 days. Or if somebody is having less than 8 cycles per year, or more than 90 days on one cycle, for any one cycle, it is classified as irregular cycle. So the history is important, and maybe 1 or 2 days outside a normal cycle is not considered to be an irregular cycle. And also in adolescence, we have to consider primary amenorrhea. So what is primary amenorrhea? The definition is, if a girl has not achieved amenorrhea by the age of 15 years, or more than 3 years post-breast development, it is classified as primary amenorrhea. So the other thing is we have to classify, we have to take history of irregular cycles. And the other thing to emphasize is regular cycles is not equivalent to regular ovulation. Some people have regular menstrual cycles, but that doesn't exclude ovulation. For example, some people complain of hirsutism, but they complain of regular cycle. When we check whether they're ovulatory or not, around 20 to 50% of women with hyperandrogenism with regular cycles may have an ovulation. So if you check the 21-day progesterone, it will be less than 30. It will show an ovulation. So we shouldn't be confusing irregular periods with ovulation. So moving on. So the first question the patient is like, what is wrong with me, doctor? So the answer is most likely about polycystic syndrome. So the next question the patient is asking, so why do I have PCOS? So is it me or something else? So this PCOS is first discovered by Stein-Leventhal. Initially, it was called Stein-Leventhal syndrome, and then it came to polycystic syndrome. We as the time moves on, we as society will change names. For example, there is no more diabetes insipidus; it is AVP deficiency or AVP resistance. Like now, there is a move to classify to change the name of polycystic syndrome to metabolic reproductive syndrome or reproductive metabolic syndrome. So that is one thing. And the main point is it is a syndrome; it is not a disease. Type 1 diabetes, we know, is a disease because we know the exact etiology. It is autoimmune destruction of beta cells of the pancreas. But for the PCOS, we are not quite sure. There is multiple schools of thoughts, multiple potential etiologies, and the clinical expression varies. So these are considered to be the various etiologies. This by itself is a class for another day. So single nucleotide polymorphism are described in PCOS. Endocrine disruptors like found in plastic, phthalate, bisphenol A is implicated in PCOS, cantineurons, GnRH pulse regulators. Another school of thought, it is due to defective insulin signaling. And some people consider ovarian hypertensinemia as the primary cause of PCOS. So it differs. So we had to, so that is why it's a syndrome and expression is varied. So the answer to the question is, yeah, there is a lot of things which we can think about, but we don't know definitely why you have the PCOS. So the next question is, doctor, how do you know that I have PCOS? So, you just took some history and you think I got PCOS, so how do you know? So we had to do some tests. So this is a choice of tests. So please do choose one of them. There's no trick questions. Straightforward. The next step would be to check their free androgen index. We'll go through why it is. So this lady doesn't have any clinical hyperandrogenism. She just has irregular periods. So sometimes, even if there's no hirsutism, they can have biochemical hyperandrogenism without clinical hyperandrogenism. It's opposite to idiopathic hirsutism. Idiopathic hirsutism, we see hirsutism, but the androgen level will be normal. So what happens, it may be because we're not measuring the androgen properly, or some women are more sensitive to their existing androgen. So that's the reason maybe we have to check whether biochemically they have got raised androgens. So yes, it is a free androgen index that we check, and it's a combination of total testosterone SHBG. And as you can see from the lab, it is normal. So does she have PCOS? So just have irregular periods. So does she have PCOS? So that is where this diagnostic criteria came up. There is there's various schools of thoughts, various society. So they have got different criteria. So, but the one which we follow is UK is a Rotterdam criteria and over the world. And it is first come up in 2003. So there were 3 parameters: clinical or biochemical hyperandrogenism, ovulatory dysfunction, and PCO morphology. If you have got 2 out of 3, you're supposed to have polycystic ovary syndrome. So based on that, various permutation and combination, there are 4 different phenotypes. The classical phenotype or phenotype A, it has got all the 3: hyperandrogenism, ovulatory dysfunction, PCO morphology. While as phenotype D, it just don't have hyperandrogenism. It just have ovulatory dysfunction and PCO morphology. So why is it important? There is some studies which suggest that the phenotype D that don't have hyperandrogenism, their prevalence of metabolic syndrome is slightly lower compared to the other phenotypes, but it is higher compared to control. So that may be one reason. And the other point to consider is there is some evidence to show that the severity of menstrual dysfunction or irregular period is a predictor of insulin resistance. So these are controlled women, and as the period length increases, the insulin resistance increases. So that may be one of the reasons why the period length is important in women with PCOS. And the next thing is, so yes, free androgens is important because that is one of the important criteria for diagnosis of polycystic ovary syndrome. So we need well-validated assays. So we used to use direct immunoassay, but most of the lab now use tandem mass spectrometry. You need to know which method your lab uses. The equilibrium dialysis calculates free testosterone, but it's only available in research labs. In Hull, we are a bit sexist. For men, we use direct immunoassay. For women, we use tandem mass spectrometry. The rationale is that at the level, at the male range, direct immunoassay is as good as tandem mass, but in lower ranges in women, tandem mass fares better. And SHBG, low SHBG is a reflection of obesity and insulin resistance. So some studies shows that low SHBG by itself is a better diagnostic marker than androgens. But the caveat is that SHBG can be raised in other conditions such as cirrhosis, medications, hypothyroidism, and also, as you all know, in combined oral contraceptive people. So free androgenic. So you heard about other androgens, DHEAs, androstenedione. When will you measure it? I usually measure it if somebody is having hirsutism with normal free androgen index. So just check whether other androgens are raised, especially androstenedione. It is not bound with SHBG, and some studies have shown that it's a better sensitivity than total testosterone to predict the metabolic phenotype. So if the free androgen index is normal, somebody has got hirsutism, so just check the DHEAs or androstenedione is raised or not. So in this case, irregular periods, normal testosterone, free androgen index, DHEAs and androstenedione normal. So what next? So when you look at the Rotterdam criteria, so she just have irregular periods. She doesn't have biochemical or clinical hyperandrogenism. So the next step would be to check PCO morphology by ultrasound. So the Rotterdam consensus criteria, it is in 2003. You have to use what you call transvaginal ultrasound, and they got specific criteria on like it should be more than 12 follicles, 2 to 9 millimeters more, with an ovarian volume of more than 10 ml. But this was done in 2003. Since then, technology have changed. Now we have higher resolution of ultrasound. So if you use this high resolution ultrasound, more than 50% of young ovulatory women will have this PCO appearance. So the Androgen Access PCOS Society has said that now with the modern ultrasound, maybe we had to have more than or equal to 25 follicles per whole ovary. And ultrasound is useless in people in adolescence or somebody who has not reached gynecological maturity, because there is high incidence of multifollicular ovaries that is similar to polycystic ovaries, so we won't be able to differentiate that. So there is no point doing ultrasound in adolescence. And also, you might have had some result suggesting that, yeah, you might have polycystic ovary syndrome. There's multiple cysts consistent with polycystic ovary syndrome. But for the thyroid nodule, if we say BTAU3, everybody knows what BTAU3 means. But for ovarian ultrasound, sometimes that is not uniform. So there's a push for a minimum reporting standard, like what is the transducer band frequency, how many follicles, ovarian volume, etc. But the main thing is, I don't do ultrasound. Some endocrinologists do ultrasound of ovaries, but I don't do, and most of the endocrinologists don't do. You need an equipment, there's a waiting list, and there is some intraoperator variability. So, I would do ultrasound only if I need to, if I can't fulfill the other criteria. So now there is a push towards using anti-Mullerian hormone in the diagnosis of PCOS. So AMH, as you know, is produced by the Sertoli cells in male, and it's important for regression of Mullerian duct during sexual maturation. But ovaries also produce AMH, and the level of AMH is proportional to the number of developing follicles in the ovary. So there is various studies which have shown by using AMH, we would be able to differentiate PCOS and control, and can be used as a surrogate for polycystic ovaries. But until recently, the school of thought is it is not yet used as an alternative for the detection of polycystic ovary morphology, because there is no standardization of assays, and there is no established cutoffs. And we are not validating different populations, ethnicities, etc. So, but in the American Endocrine Society meeting a couple of weeks ago, in the last one, there's a presentation on international consensus criteria on PCOS. It will be out. It will be published in August 2023, in a month's time. So they have proposed that we can use either AMH instead of serum AMH. It's a blood test, serum AMH instead of ultrasound ovaries. So I not changed my practice yet, but you can see that is where we are all going. And the most important thing is as I mentioned, 9 out of 10 cases we can just, by history, we know polycystic ovary syndrome. It is the PCOS is a diagnosis of exclusion. So the commonest thing, hyperprolactinemia, thyroid, premature ovarian failure, we have to exclude. And also we have to consider other causes, like if the testosterone is twice the upper limit of normal, tumors, DHEAs will be raised in adrenal tumors, while androstenedione more point towards ovarian tumor or non-classical CH, where we measure baseline ACT stimulated 17-hydroxyprogesterone. And if you clinically suspect Cushing's or acromegaly, we have to do investigations as appropriate. Okay, so we can go to the next case. So this one is a 16-year-old female. She had her menarche at the age of 12 years. She had amenorrhea for a year, and for the last couple of years ago, she has got acne and hirsutism. She's overweight, some acanthosis. She has gone through the puberty, negative HCG, pregnancy test, FSH, TSH, prolactin, and selenol, they're all normal. And she has raised testosterone and free androgen index. So this case, it is difficult to make a diagnosis. It could be challenging, especially in adolescents, to make a diagnosis of polycystic ovary syndrome. Because as I mentioned before, the irregular cycles are common until 8 years after menarche. And acne, both boys and girls have acne in adolescents. And ultrasound is not of much use because it can show multiple patterns. So it could be sometimes challenging. There are some pointers is that yes, acne is common, but hirsutism is not a common feature in adolescents. Also like a male type of baldness or anything. So if you can see that point more towards polycystic ovary syndrome, and it is important not to label a young girl with PCOS, and sometimes it's better to follow for certain and till the things become more clear or till she achieves reproductive maturity. So this girl came with the mother, and she's asking, what is wrong with my daughter, doctor? So the adolescent diagnostic criteria is much stricter. So you have to have irregular periods, which is abnormal for the gynecological age, and they should have persistently irregular periods, and they should have both clinical and biochemical hyperandrogenemia. So you have to fulfill those two criteria just to diagnose polycystic ovary syndrome in adolescents or somebody who has not reached gynecological maturity. And also, sometimes we could use increased risk of PCOS. For example, we use increased risk of diabetes between the HbA1c of 42 to 48. Meanwhile, you can use increased risk if you say that the diagnostic criteria is not clear-cut, but you strongly think that she could be having PCOS, and she could be worked up later once she reached full reproductive maturity. So the next thing is how to treat this young girl, or how to treat anybody with polycystic ovary syndrome. It depends on what is the main concern of the patient. The symptoms of concern in younger women is more towards reproductive abnormalities, while the older woman is usually the metabolic abnormalities. For example, adolescents, they usually complain of irregular periods and hirsutism is the main complaint. While in the slightly older age group, the fertility is a concern. While in older than other age group, the metabolic abnormalities like risk of diabetes could be the concern, or endometrial pressure is concern. So the treatment depends on what's the patient's main symptoms of concern. So this is not a question, but these are the various things usually the women with PCOS comes up with: menstrual irregularities, contraception, hyperandrogenic symptoms, fertility, metabolic and endometrial perfection. So first thing is asking a mother and daughter, what is the symptom of, or daughter, what is the main symptom for you? For our patient, her main symptom of concern is irregular periods, contraception, hyperandrogenic symptoms. So in the interest of time, don't want to go through the poll Kavita, if it's okay. There's a few slides. Okay, so somebody has already made choice. Yeah, we can go with it. There is no right or wrong answer, and I'm not giving you an answer in this.
Apologies, I think I ended the poll very quickly.
That's fine, that's fine. Yeah. Yeah.
I think
okay, I think that's fine.
Yeah.
So yeah, there is no right or wrong answer. You could do anything, but maybe we will look at diet and lifestyle modification. So it is supposed to be the cornerstone in the management of polycystic ovary syndrome. But there are various studies which on lifestyle intervention like diet and exercise in women with PCOS, and the results are not that dramatic. For example, the systematic review on insulin level with lifestyle intervention. Yes, there is some slight improvement, but not much. So lifestyle intervention may improve everything in PCOS, but it's very difficult to achieve. So what is the most important thing in managing PCOS is weight loss. If they lose weight, around 5-10%, if they lose weight, all the symptoms will improve. And on the corollary, if they put on weight, all the symptoms will worsen. It doesn't matter. So for example, in after bariatric surgery, where there is significant weight loss, their insulin resistance, fasting insulin, everything has reduced, as well as clinical and biochemical hyperandrogenemia. So there is significant reduction with bariatric surgery. So the point is, so if you lose weight, it doesn't matter whether it's diet or lifestyle intervention or bariatric surgery, or there are now different pharmacotherapy for obesity in the horizon, like GLP-1, receptor analog, twin incretins, triple agonists. So if they lose weight, the symptoms should improve. The mainstay, especially for our patient who complains of menstrual dysfunction, contraception, and hypertension, the mainstay of treatment would be combined or contraceptive pill. And it is the estrogen component of the combined contraceptive pill is important. And the progesterone only pill, they don't have much effect on hirsutism, although they can regulate the periods and give endometrial protection. So combined oral contraceptive is the mainstay of treatment for polycystic syndrome, and it is recommended in most adult women with PCOS. Before that, our favorite was Dianet with 35 microgram estradiol and cyproterenastate. It's no longer the favorite because there is slightly more increase in VT risk. So any contraceptive of choice, any combined oral contraceptive the patient prefers, which contains at least 20 to 30 micrograms of adrenal estradiol, could be preferred. And there is various contraindications like obesity, smoking, whether to use, whether to not use. For counseling, I think if you look at this UK eligibility criteria, UK medical eligibility criteria for, then you would be able to come up with it. The main risk of combined oral contraceptive, especially, is the VT, venous thromboembolism risk. But this group of women, they are really, really young. And so the absolute risk is really low. So it is the incidence of VT, although there is a slight relative increase in risk, absolute risk is really low. But only the couple of conditions which we should not use combined oral contraceptive pill is somebody who's a BMI of more than 35 and more than 15 years of smoking, and also migraine with aura because it's increased risk of stroke. So these are the conditions in which we shouldn't be using combined oral contraceptive pill, and everything other is relative. So for this patient, we advised on lifestyle measures, started on combined oral contraceptive pill, and the patient returns in 6 months and still have complaints of hirsutism. So the main point to note is it takes at least 3 to 6 months for any intervention to work. So till then, they had to resort to physical things like laser or other mechanical means. You don't want Kavita, that's fine. So we got spironolactone as the main, and then metformin, flutamide, stop contraceptive pill. So there is a wide thing. So there is no right or wrong answer, but we thought in this lady and this girl, we will go with some anti-androgen like spironolactone. So for her, we added so diet and lifestyle modification is already going through. We don't know how much she adheres to. She's on combined oral contraceptive pill, and we added anti-androgen. So the spironolactone is the commonest anti-androgen we use. The 3 points: one, for the heart failure we give 25, 50, but here we can give to the young woman, we can give 50 to 100 milligrams daily. Sorry, 100 to 200 milligrams daily. That is one thing. And second thing is we had to use some form of contraception when we're prescribing spironolactone, because it could prevent the development of external genital if it's a male fetus. And the third thing is if you just use spironolactone without anything else, it can in fact make the cycles a bit more irregular. And this is the commonest anti-androgen which we use, and we'll check the potassium to make sure it is normal a week after starting spironolactone. So for this lady, we added some spironolactone on contraceptive pill, and then mentioned that it will take at least 6 months to benefit treatment. And then she came after a year because of the waiting list and others. And the GP, the interesting thing is the GP has started metformin after 6 months. And her hirsutism has improved, but she has put on weight. So what is the role of metformin in women with PCOS? We commonly use metformin, and it's all expert consensus. There is no real hardcore evidence for it, but it shows that metformin could improve restores ovulatory period in 30-50% of people. And also there is some evidence to show that it can improve weight with lifestyle modification, metformin. So metformin is the treatment of choice with women with PCOS having metabolic abnormality like impaired glucose tolerance and type 2 diabetes. So the international PCOS guidelines recommend metformin could be used in managing weight, hormonal, and metabolic outcomes in women with PCOS, especially at the higher metabolic risk group. And these are the other anti-androgens which we use: finasteride, 5-alpha reductase inhibitor, flutamide, tetracycline, trilogy, artenologues, and eflornithine, which is not of use. So these are the various anti-androgens we rarely use. And the other interesting thing is there is no right or wrong answer. We can, like in diabetes, we can just combine different preparations. Like we can combine contraceptive pills with metformin or with anti-androgens. And the last Endocrine Society meeting, there was a presentation they are doing in Spain, a study on something called Spiomet. It's a combination of spironolactone, pioglitazone, and metformin, a single tablet for the treatment of polycystic syndrome. The results, we don't know the results yet, but the thing is we can just choose to combine various treatments which we can use. So thank you. Sorry, I slightly run out of time, but thank you. Anything, I'm more than happy to ask questions if there is time.
Thank you so much. There are actually quite a few questions on the chats. About 8 questions.
And we have time because we've allocated a 10-minute extra slot, so please do go through all of them.
Oh, fair enough.
I think the first question is, what is the pathology behind high biochemical androgen with no hirsutism?
It's all, it just can happen both ways. Some people, they are more sensitive to their androgen. Some people are less sensitive to their androgen, their skin, the receptors. So that may be the reason why some people's androgen will be slightly raised, but they don't have hirsutism. And some people's androgen levels are normal and they could have hirsutism.
Okay. Thank you. And what would be the approach in young lady with hirsutism and mildly elevated androstenedione? Rest, all the other hormones are normal, and Cushing's has been ruled out.
So the young girl who has got slightly raised androstenedione,
Yes.
but periods irregular.
Not sure. Nina, do you want to unmute and ask the question?
Hi, thank you for a brilliant talk. Yes, the patient's periods are not regular. She's amenorrheic, but her main concern was hirsutism. And to add on this question is that her ultrasound ovaries showed 13 mils of left ovary.
Yeah, I think so. She has got irregular periods, slightly raised androstenedione and hirsutism. Maybe I would classify her as an increased risk of PCOS, but start on combined oral contraceptive anyway, if she's willing, and then maybe reassess at a later stage.
Yes, sure. Thank you.
Thank you. The next question is, will weight loss improve in the symptoms in normal BMI PCOS patients?
Yeah, that's a good question. The thing is, what is normal BMI? The BMI for somebody, it all is a physiological set point. So, if somebody is with a normal, considered to be high normal BMI, if they lose some weight, their symptoms could improve, but the bang on the buck would be lesser rather than somebody who's really overweight. But yes, lifestyle modification do work.
Okay, thank you. Another question is, if there's a unilateral polycystic ovarian morphology, can that indicate PCOS? So, for example, one of the two, oligoamenorrhea or hyperandrogenism plus unilateral PCOM on ultrasound, would that classify as PCOS?
Yeah, the other two by itself, they can classify polycystic ovarian syndrome in the irregular periods and hyperandrogenism. So you don't have to always do this ultrasound ovary. So, but yes, unilateral pathology, if only one of them is there, and the unilateral pathology, which is the ovarian morphologies, ovary is enlarged and it's got follicles, it could be considered polycystic ovaries.
Thank you. Another question is, would you still offer OCP to regularize menstrual cycle in someone who desires pregnancy?
Not really. I think we are defeating the objectives. And if somebody's trying to get pregnant, I think maybe there are a lot of other things which we could use rather than contraceptive pills.
Okay. And how to manage the irregular cycles caused by spironolactone?
It is very difficult. It is maybe we had to use, or ideally use combined contraceptive pill or Mirena coil, if they do, or progesterone preparation. So it is tricky, but so what the point I tried to come across is somebody's just on spironolactone. If the periods get worse, it's nothing abnormal.
And how often do you check renal function test on spironolactone, and how long will the spironolactone treatment to continue? Is there a break period?
Really, but the thing is that, like, if maybe what I'll do is after checking, I'll ask a GP to check in a week's time to see potassium is normal. But maybe 6 months or a year, I will review it. If there is some significant improvement, then I will carry on along a piece of string. But if there is not much improvement, or if it is plateaued, then I will give them a trial of spironolactone.
Okay. Someone's just made a comment why metformin still remains off license for PCOS treatment.
That's a good question, but the thing is, like, there is not much. Metformin is a generic medication, and nobody will push metformin. No pharma will push metformin to go through the regulatory process.
Okay. And can we use metformin in PCOS without having diabetes or pre-diabetes with normal BMI who seeks fertility?
Yeah, there's not much evidence. There is a lot of other fertility treatment which you could use, but yeah, metformin, there's no harm in giving metformin.
Why is LH-FSH ratio no longer used as part of diagnostic criteria?
Yeah, fair, because LH and FSH, they are pulsatile and they're not well validated in other studies. So that is the reason why it has not come up in diagnostic criteria for PCOS.
Okay. And for patients who wish for fertility, the combined oral contraceptive pill is not the treatment of choice. And so the question is, how do we manage them? Do we refer them directly to fertility?
It depends on your comfort zone. Some endocrinologists do manage it, some people will refer. It may be, but we could start on metformin, letrozole, or refer to, if you're working closely with a subfertility unit, you will do a joint management. It all depends on so there's a lot of options available for fertility. The main thing to a lot of women I see, they are concerned about this fertility. Young women, even they're not planning pregnancy, the main concern is, am I infertile?
Okay.
That's the main reason. The answer is no. And the other thing is, some people, they think that their periods are irregular, so they're not fertile and they don't use contraception, and they will have unwanted pregnancy. So it is important to counsel that irregular periods, they can still ovulate even if the periods are irregular.
The next question is, what will be your choice of treatment for hyperandrogenism symptoms in someone where COCP is contraindicated, example, severe obesity, and in patients who are intolerant to spironolactone?
You can use, it is for doing hirsutism, is it?
Yes.
Okay, the thing which we could use is maybe finasteride.
Okay.
5 milligrams daily. The main thing with the finasteride is, there is we shouldn't be monitoring testosterone levels on finasteride. It's a 5-alpha reductase inhibitor, so the testosterone level actually goes up once you start finasteride. So yeah, so that has to be careful. But yeah, that's another alternative which we can use.
The next question: do weight loss, lifestyle modification have any effect on hyperandrogenism?
Yeah, as I say, it depends on how much weight you can lose. But if you lose significant amount of weight, like we saw in bariatric surgery, or with newer medications in the horizon for obesity, they can have significant improvement in hirsutism. The main thing with hirsutism, it will take at least 6 months to have its effect, because the follicles has to change and regenerate. Yeah.
I think the next question's already been answered, but at what point should you refer PCOS women seeking pregnancy to fertility unit with evidence of disordered ovulation? I think you talked about that.
Yeah, and the main thing with referring to fertility unit is, we always blame women for PCOS for subfertility, but you have to check men as well, because we shouldn't automatically assume that the woman has got PCOS, so it is her fault. So it may be, we have to look at both the partners rather than just the
yes
women.
Okay, right. Thank you very much, everyone, for the opportunity to speak to you today. So I'm a consultant endocrinologist that really focuses on the treatment of men and women with reproductive disorders. And I've been tasked to you to talk about a really important, but because it's uncommon, it's difficult to I guess, get pattern recognition and a head of steam in sort of getting used to how to manage an uncommon but not rare group of men who basically have hypogonadotropic hypogonadism. So the good news is what we're going to do in about 20 minutes or so is cover everything you need to know, and we'll sort of hang it around a case so that by the end of this, you'll know exactly what to do. A little bit of background. So, spermatogenesis, you would have learned from medical school, consists of a 3-month process whereby germ cells undergo mitosis and then meiosis. And then this kind of, it's almost like, I see it kind of like a school, they kind of graduate into these spermatids. And then a process which require, now that whole thing is supported by nurse cells called Sertoli cells, and that's driven by FSH from the pituitary, which needs GnRH and the Candy neurons. But LH is needed to synthesize very high levels of testosterone in the Leydig cells of the testes. And can you see, so the serum, you have sort of 10 to 30 nanomoles per liter, but in the testes, you have about 10 to 20 times that much. So you have this kind of furnace of very, very high intratesticular testosterone. And that's what you need for the final stage of sperm maturation. To make spermatids into spermatozoa with the tails, you need that very high level of testosterone. So you get the symbiotic relationship between FSH, which does everything apart from maturation, and then LH, which mediates maturation. And that's how you make sperm. So during pituitary failure or higher up sort of hypothalamic failure, you end up with the same thing, which is low LH and FSH, and you basically get a blunting or absence of this. And that may be also caused by, and what we typically do for these men until they want to father children is put them on testosterone. And can you see that there's a fundamentally different way their physiology works with regard to testosterone? They have say, I know it probably, there are wider excursions with libido, but you're aiming for normal sort of 10 to 30 levels of nanomoles per liter of testosterone in the circulation. But you also get that in the testes. You don't get that very high intratesticular testosterone, and therefore you cannot make sperm. Okay, good. So broadly speaking, from first principles, what you really want to do with sperm induction is for a small period of their life, is flip things around so that you are recreating the conditions so that they can make sperm. And it's really inconvenient, and it's probably inferior for their health compared to testosterone. And that's why it's a temporary phase of their life. Now, there are a few ways that one could do it. In a research setting, so in America and France and Switzerland, they sometimes actually connect. Now, this is the mainstay, so gonadotropin therapy, which is what I'll be talking about. So things such as HCG and HMG, which mimic the gonadotropins. But these things can also be used, but are not ideal for various reasons. So a GnRH pump can be used in a research setting, but is prohibitively expensive and impractical, and the pump's not available. And the problem with sort of these other drugs, anastrozole and selective estrogen receptor modulators, is that they rely on reducing feedback in the pituitary. But if you've got a pituitary that isn't working, then they're not going to work. So really the mainstay of treatment in men with hypog is gonadotropins. Okay. So let me just, so this is a poll, Kavit, so if you can do a Zoom poll. So this 28 it's a little vignette. So a 28-year-old man is under your clinic and has been for a long time. And they've been basically on libido. And when they were referred to you, they, they said, well, I didn't go through puberty, and at age 16 or 17, the pediatricians gave me testosterone. They gave me some injections, and now he has sort of, secondary sexual characteristics. When he's off libido, his LH and FSH are well below the reference range, and his testosterone is only 3. And he's had his last libido injection last week from the GP. So I'd like you to sort of vote and tell us, what do you think we should do now? Now, more than one answer is okay. I don't know if Kareem, more than one answer is possible, but select any of these which you think might be suitable things that we should be doing now. Okay, but it'd be interesting to see what everyone holds. Thank you.
And if the
Give a minute more.
in the way, you can move it. You can move the poll thing out of the way so you can see the options. Each of you can do that individually. So can we all vote, please? All 89 of us?
Okay, very interesting. So if everyone can see the screen, so
They can't.
Everyone likes E. D is reasonably popular. Basically everything apart from 3. So what I would say is, for those of you who are polling the gonadotropin responses starting HCG, you're not wrong. However, and I guess probably we would be doing that, the things we want to do first, maybe I didn't word it well, were it's vitally important, first of all, to ask about the partner, okay? Because this partner might, so let's say they have 3 kids already. That means that, and let's say the partner is 43 years old, then their actual chances of getting, having another baby go down a lot, okay? Or maybe the partner has amenorrhea and obesity, and we're increasingly seeing that. So asking something about the partner's age, weight, and periods is vital. Testicular volume is really important as well, as I'll talk about, because that, you want to get a sense of whether if he has very small testes below 4 mils, that suggests he hasn't had any puberty exposure whatsoever, and that may make us a little bit less optimistic about the chances of successful sperm induction. I would, because he's had a massive slug of libido, it's a little bit tricky because he's had that injection last week, hasn't he? So giving him HCG will push up his testosterone more. So I'd be tempted to, you could either wait until his next libido injection is due and give him switch to HCG, or you could switch him to a gel, and then when he wants to start, then it's very easy. You can just stop the gel one day and start HCG the next day. So I tend to think switching to a testosterone gel is a good early way of transitioning someone. It's a bit more logistically tricky when they're on libido, because if they just had an injection, you can't really give them HCG at the same time. We can have questions on that. We don't give any recombinant agents, so HCG is just as effective as recombinant LH. So we don't give recombinant drugs. Okay, so, and this is all on the Imperial Endo website. So in terms of what we start with HCG monotherapy. Now there's a guideline on hypogonadism we've recently published, and actually there's a slight variation on this. So we normally start with HCG monotherapy. I think when you think someone has had no puberty exposure at all, or even has very small testes, we might start with FSH as well. But as a basic established protocol, this is what we do. At 6 months, if they actually haven't had any sperm ejaculate, then we would add in something called HMG, which is menopausal gonadotropin, and that has high FSH activity and is much cheaper than recombinant FSH. And I give an indicative doses here. And what we're aiming for is getting the test, tweaking around and increasing the HCG until testosterone levels therapeutic, and increasing the FSH dose gradually as you see them every 3 months. Now, a lot of patients by 12 months will have sperm in the ejaculate. And as I'll show you in the next slide or two, 24 months is the maximum time for response. And in general, you want to be checking serum testosterone because that's the furnace. You want to be increasing menopause dosing so that they have FSH exposure. Some centers advocate measuring serum FSH as well. And the semen analysis, although I don't really do that until 6 months because 3 months is very early to be responding. Okay, so it's really important to check at baseline a testicular volume, because most of the testicular volume is sperm making machinery. So you can use this as a way of monitoring progress. So I tend to check it at baseline. And I will check it at 1 year if there is euspermic as well, just to see if there's been any increase. Okay, so this is another question. So getting back to our patient, again, I apologize, there is more than one question that is reasonable. So which of these do you think could be a factor which influences his chance of successful sperm induction? Do you think, first choice, prior testosterone treatment, which he has had, will influence detrimentally, I guess, the chance? Whether his hypogonadism is congenital, which he has, or acquired, such as pituitary surgery, the age of his partner, or adding FSH. Which of these do you think influences, modifies the chance of success? Fantastic. Okay, so B is the most popular, and you're right. So we do know that the chance of success is lower if you've had congenital hypog. So if they have pubertal failure, then you can't guarantee that their testes fully formed, the seminiferous tubule, the factory fully formed. Now, as I'm going to show you, but there's no evidence that prior testosterone treatment is detrimental to treatment, which is really good for us because patients have a habit of like looking on the internet and saying, no one told me that this testosterone has been damaging my testes. Well, that's not true. You can say that there is evidence that against that. Now, it hasn't been reported, but I think it's intuitive, and you know, we're doing multi-center audits, which I'm sure will show this, but I think we're increasingly seeing that men are having successful sperm induction but not having babies because they're trying to have kids later in life, and their partner is also having kids later in life as well. And addition of FSH is actually, I'm going to show you data from a really nice meta-analysis, is a really nice factor which boosts the chance of successful sperm induction. I think in hindsight, if you look at the context in which FSH was licensed, the reason we add it in later is to save money because some men, particularly when they're acquired, do respond with HCG alone. But particularly with these men with congenital, they almost always need FSH added. Okay. So this is a really good meta-analysis published from this Italian group that does a lot in this work. It's a really good read if you want to kind of update yourself on the evidence. But basically what this shows is a forest plot, and this is looking at different types of factors. So if you can see here that having pituitary-related hypog has an 80% chance of success for sperm in the ejaculate, at least one sperm in the ejaculate. But having hypothalamic, so congenital-related hypog has about a 60 to 70% chance. And that's really important. And on day one, when I treat them and start the drugs, I have this conversation and I document. It's really important. Otherwise, they will assume it will work. And that's a horrible conversation to have 2 years down the line. The other thing to say is, look at this. It's unequivocally, there is a much better chance of, you have a 50% chance of sperm induction with HCG alone, but a higher chance with FSH. So by FSH, I mean we give HMG, which is cheaper, menopausal gonadotropin, but same thing. And my rationale is I will, if someone has had pituitary surgery, so is acquired, just start with HCG. I'm leaning more if someone has failure of puberty to start both of them together, because we know that the chance of sperm induction is better with both. But that's a point of controversy. And can you see here, there's no significant difference in terms of having previous testosterone or no previous testosterone. And in fact, what they did was do something called a meta-regression. Now, let me explain this to you. Each of these circles looks like a sort of a Death Star, and each one of them is basically a study. The bigger the study, the bigger the Death Star. And what they did was look at, on the right, these studies almost all had people on previous testosterone. And on the left, none of them had testosterone. And if testosterone was bad, you'd expect this line to slope downwards to the right. And this line does not slope statistically significant from the horizontal. And therefore, this meta-regression fails to show that testosterone is detrimental, which is really good counseling for us. Okay, now if we look at mean sperm concentration, very similar things come out. In other words, people with pituitaries are likely to get away with higher sperm counts. And FSH, can you see with HCG, you don't achieve much sperm, but with FSH, you achieve much, much better sperm on average. And again, with previous testosterone, there's no difference. So this is a really important slide. So what factors influence the success during sperm induction? Things that increase likelihood intuitively are puberty. So if someone's had intact puberty, that's a really good sign. If their testicular volume is greater than 6 mils, that's a really good sign because it means that some degree of development has happened. Okay, so someone who has pituitary surgery and is hypogonadal will never drop below 6 mils because their testes have been formed. Okay. And undescended testes is a bad sign. Again, that's a sign of insufficient, that the lack of puberty, the hypogonadism, might have actually extended in utero and into mini puberty and prevented testicular descent in utero and in infancy. So these are soft signs that make you think, this may dial down our expectations. But FSH increases likelihood of success, but the type of FSH, so using expensive recombinant FSH, does not improve success rates compared to cheap. Well, it's not cheap, but menopause or menotropin and previous testosterone use is essential for people with this diagnosis and not detrimental. So how quickly do patients respond? So this is a brilliant study by Peter Liu and lots of Australian colleagues. And what they did is kind of like a Kaplan-Meier plot. And there hasn't been a study better than it. And they basically looked at 75 men. And can you see, if you follow my cursor, which I hope you can see, this is the probability of seeing sperm at different times. So the months are on the x-axis and the probability is on, in percentage, is on the y-axis. And as you can see, the peak response for sperm is seen at 24 months, okay? And by extension of that, from an evidence base, that's the maximum that we would counsel people that we would see responses to. And I personally haven't seen a response beyond that time. Now, the bottom line shows the probability of seeing any sperm. And actually, to tell the truth, there have been a couple of cases of responses up to 30 years, up to 3 years, although I haven't seen any cases, and we do persist in people who are persistently, that's the normal sperm count. That's why it's so low. So this is actually achieving a normal sperm count. And as you can see, only half of people will ever achieve that. But the open circles is what's most important, is actually getting pregnancies. And what you can see is that actually getting pregnancy does not need a normal sperm count. Getting pregnancy is much easier. In fact, it corresponds roughly to about 5 million sperm per mil. So what this means is these couples are having sex and with a man who has no sperm. But once he gets a little bit of sperm ejaculate, then provided the female partner is well, then they got a good chance of getting pregnant. Okay, so the median sperm concentration during pregnancy is 8 million sperm per mil. But I think this was done at a time where it doesn't really account for female factor infertility and couples trying to have babies in their early 40s. So this is the bottom line. So how quickly do patients get pregnant? Well, it takes 24 months to see any sperm in the ejaculate and 36 months for pregnancy. So patients need to be counseled, but this is a long term, this is a long game. And this doesn't provide pituitary specific data. So it may be that pituitary patients will respond quicker. And actually this long tail of response is more in the congenital group. So what counseling should we give our men? Well, I think expectations are really, really important. So give the chances and success of timelines, which I've hopefully given you, and accept that sometimes, particularly where you have an older partner or partner with female infertility, then they may need things like assisted reproductive technologies. So once you have sperm and you realize that they're not getting pregnant, make sure the woman gets referred by her GP to a fertility clinic so that she can have a check if she's got blocked tubes, all those basic things, which should happen in parallel. The GP is normally very happy to do this. And also check, I always check, like, do you have any kids? It sounds really obvious, but they may have a partner who already has kids. So again, if they have kids, I always counsel them that, let's say they're a couple in their 40s and you're embarking on this, spending a lot of NHS money. If they have 3 children already and they're in their 40s, then saying, well, do you have the money to do private assisted reproductive technology if this doesn't work? And if clearly that, you know, IVF doesn't really work beyond the age of 42, 43, then I think it's a very difficult conversation, but I think we probably should at a certain point be setting limits on who we offer this to and who we don't, although those don't formally exist for male fertility. And family planning, always remember, always ask about the partner. It sounds really obvious, but I have had people, you know, who have been in different countries as their partner, and it's really obvious that it's being in the same country is very good for fertility. So advising regular intercourse. Once any sperm are seen, there's no need to time intercourse to the menstrual cycle when you have a poor sperm count. At least once or twice a week is great. So in summary, gonadotropin therapy is the treatment. For pituitary disorders, there's an 80% chance of success, but it's lower, about 50 to 60 if you have congenital. It takes 2 years maximum to see any sperm, but this data probably, we haven't really teased out specific data for pituitary and congenital patients, which we're trying to do. And evidence does not show that testosterone is detrimental. So really set realistic expectations at the beginning, and general family planning is very helpful. Okay, so that's been given an overview. I'm sure you've got lots of questions and I'll be happy to answer them.
Thank you very much. Can you hear me, Channa?
Yeah.
You said your 28-year-old patient wants a baby. I've got a 20-year-old who has testes of 4 mils, and he has been on testosterone since the age of 6. Okay. Under
there's no advantage whatsoever other than I think if you have someone who's remote, I think being pragmatic and just getting an ultrasound can be really, really useful. Secondly, an orchidometer, you always overestimate a bit with an orchidometer, whereas an ultrasound will give you slightly lower values. But in essence, there's no added value if you've got your patient in front of you.
Yes, no, if I've got the patient with me, so the question really is, he's been on testosterone since he was 6 years old, under peds, and now
it's just the only reliable thing we have at the moment is volume. There's nothing else you can get. So just documenting that is so important. And it's one of those things that is very easy to miss, but very difficult to go back in when you have 18 months and an anxious couple in front of you, and you want to know if there's been an increase in testicular volume. It's a very important but simple thing to have documented. So I use ultrasound, particularly when you have a remote patient who lives far away, and I get referrals from all around the country, and so I won't drag them down to St Mary's for an but I will maybe get a local ultrasound done. So that's the only advantage of it.
Can I ask a different question? I don't know if you heard me. I think Channa can't hear me, actually.
Thank you. It's a really excellent question. So I'll tell you that because there haven't been many studies done, and I've presented the best studies we've got, we don't have that granularity to distinguish between to tell specifically whether someone with really small testes has a worse prognosis than someone. Most people with congenital hypog may have 6 to 8 male testes, which are a little bit small. But if someone has things that are the size of a pea, I think we all know I can say anecdotally in a handful of cases that I haven't had much success with those. And that's what we're trying to do, is trying to pull together national, and actually we collaborate with some international groups to actually pull together and actually get that next level of data on seeing whether people with really small testes, which probably haven't formed properly in utero, whether we're getting any joy with these. I can't offhand remember getting that, I must say. So it's a really good question. Yeah, really good question. So we know that, in fact, this has been studied brilliantly. So the US government and the WHO has spent 4 decades trying to make a male contraceptive pill. And Peter Liu has shown beautifully that if you give high dose testosterone, you will temporarily, within a few months, within 3 months, lower, but not completely shut off testosterone. And you have to add progesterone on top to completely shut it off. But then it recovers in healthy men beautifully in every single man. It was published in the Lancet about 10 years ago. Within 6 months, every single person recovered, and these were large trials. So it's a temporary effect. It's like it's like a spring. It's like a spring. Oh yeah, then it's Muhammad Malik, isn't it? Yeah. So this is so the question is, would we ever consider giving FSH before starting HCG for volume less than 4 mils? Yeah. So I didn't kind of go into this one. So this is kind of a detail, and this is covered in the Bible online. There is one very small study from Lausanne in Switzerland, from a very eminent group, where they actually gave to men, you know, the ones who have below 4 mil testes, where we think they haven't properly formed. In infancy, you get, there are no, let me get this right. I think there are no androgen receptors in the testes, so you get unopposed FSH. And unopposed FSH theoretically could grow the factory before exposure to HCG. And a lot of their outcomes were non-significant, but it's made us wonder in people with really small testes, whether you give menopause, so FSH for 6 months beforehand. No one's really ever determined whether that's successful or not. I tend to do it. So if you do have someone with very small testes, then I tend to give menopause for 6 months before the protocol. But I have to say, I've never noticed any difference in their testicular volume. So we don't know whether it works or not, I'll be honest. But we do it out of faith. Yeah. Julian Wang's asked, should boys needing pubertal induction now have FSH? It seems that most, yes. That's a really, really good question, Julian. So I know that colleagues of mine, so Sasha Howard at Barts is looking into this. So people are really experimenting with whether, so the standard treatment for someone who hasn't gone through puberty is to give testosterone. And as I explained, testosterone is not bad because it doesn't do anything to hardwire the testes. The intratesticular testosterone levels are very, very mild. And so I think there's nothing wrong with achieving puberty in a boy with testosterone. Now, once you try to do it with gonadotropins, I haven't seen outcome data showing that that's better on fertility in the long term. And it'd be really interesting to see that. It seems to make sense and be more physiological. But if you do it wrong, I think that could be better. That could be worse than not doing it at all. So sticking to the basics is, so as a default, puberty induction, give testosterone, and you give it very slowly, and that's best sort of liaising with a pediatric endocrinologist and there are very good protocols online. But for us, the default is HCG and FSH. And this slight little star is that if people have tiny testicular volumes, it's a bit niche, but there is this argument for giving pre-treatment with FSH, although there's no proof that works. Message from Kareem, a 8-year-old on testosterone and wants a baby, but only in 10 years as his wife is 22. Ah, okay. So I personally strongly, I would say that being on testosterone is the right thing until someone is in the zone of, are you saying
10 more years?
Yeah, absolutely. So what I would say is that the best treatment for so they want to be dads, but they also want to be healthy men.
Yeah.
And if you look at data for bone osteoporosis, cardiovascular safety, so the FDA Traverse trial has just come out. Testosterone is an immensely good drug and has been tested and safe. If you have that person on gonadotropin for 10 years, you are making a damaged testis make testosterone for 10 years. And the one thing it will make that libido doesn't is estrogen. And the estrogen to testosterone ratio is much less favorable for a damaged testis than a healthy testis.
Yeah.
And 20% of the time they'll get gynecomastia, and that could cause blood clots as well. So we don't know.
We might be less fertile if I don't.
No.
Cut-off, age cut-off, beyond which the FSH may not work.
No. It's kind of almost on ice. So it just depends, good planning. And as long as he tells us 1 or 2 years beforehand, then I think that's what I always say. So if you know these people are out there, say, they say, oh, I've met someone and, think they're the one. Right, okay, and if they're on a libido, I switch them to a gel. And I say, okay, let's talk about it. Let's see how you are in the summer. That's very helpful. Thank you. So the best treatment for their life is testosterone. And this is an inconvenience and a suboptimal treatment, but apart from fertility. Can you please repeat the questions from?
When I talk with the client.
Okay, fine, thank you. Unable to hear questions. The only questions I've been reading have been the ones from the screen.
Read them out loud.
Yeah. Okay, there's one about funding arrangements for this in the area. Okay, so this is from Siva. This is a really good question because the SFE has formed an andrology specialist endocrine network, which I chair. And what we have is a postcode lottery at the moment where people, so if you live around the corner from us, then you're going to get excellent care, but we're concerned about someone falling between centers. And so we now have 12 centers around the country where we have from our pharmacy budgets. So we've clarified with NHS England, and they've declined to centrally fund this because it comes out of specialist budgets. So endocrine departments in Birmingham, Newcastle, Manchester, etc., there are certain centres that have this funding. And what we basically say that we should be hub and spoking and referring to those centres wherever you are. And we have a good number of centres, including Wales and Scotland, where this can be delivered. At what point after 2 years do you say it's not working? Yeah, I tell you what, if it's not working after 2 years and you've got optimal treatment, one thing we are interested in trying to do, again, I wanted to focus this really on the nuts and bolts of what you do, is with men with azoospermia, with primary testicular failure, we are doing surgical sperm retrievals. And what we're trying to answer, which no one knows about, is if you have these men who are on optimal treatment, is there a little bit of sperm in there that we're not getting to? And so if you do refer them to us, then we would be happy to do a surgical sperm retrieval to actually answer the question if they wanted to know. And the idea is that we could store the sperm, freeze it, and if there was anything that could be used for their partner. But the answer is we don't know. Now, they may also, I think it's really important when you have unsuccessful fertility treatment to counsel people about other options. It's very brutal, but there are fundamentally, there are three alternatives. Number one is going for donor sperm IVF, where essentially the couple has IVF, but they buy sperm through the units from an authorized supplier. Number two is adoption. And adoption, there are barriers to it, but essentially it's through the local authority. One condition is that you must not be actively seeking fertility treatment because there's a risk of rejection of the adopted child. And the third, of course, is accepting childlessness. And I think it's really important that at that sort of stage, you start to sort of have these discussions about what you want to do. I think it's all, I would not sort of turn the tap off immediately, but I would probably sensibly have that counselling and give them 6 months to a year extra, but then agree upon some. So I have one patient who's got Cowman's, referred from Bart's, has had a terrible time. His marriage has broken down over the pandemic. He's lost his job. He is 4 years into sperm induction, but it's been suboptimal because he's forgotten a lot of the time. He started with 2 mil testes, and we're going to do microteasy because he's married again, and he really wants to. He's from a traditional Asian background, and it's very important to him to find out. So that's what we're going to do. So there are kind of rules, but there are rules to be broken as well. The chances are very low, but he absolutely is determined. And the thing is, if we don't do it, someone probably will. Okay, and what is the risk of VTE when inducing spermatogenesis? Good question. No data at all. What is the risk of VTE when you take testosterone? No reliable data. But I draw your attention to the New England Journal Traverse trial, which got published this month, and you know the risk of VTE has not been shown to be significantly above placebo in testosterone. But what I would always counsel anyone taking testosterone or anything that increases testosterone is that there is a risk of VTE, but you have to say, are the benefits greater than the risks? So I always say, and I always document, anything has a chance of inducing VTE, and I would not give this therapy to someone without benefit. If azoospermia, oh yeah, so Julian Wang is asking, if someone's azoospermic after sperm induction, what is the success rate for microteasy? I'll let you know when we find out. No one knows. It's so it's something that we want to find out about and see. What's the usual advice given to patients on testosterone? Anna Priya, so I would probably draw attention to these slides. I'm happy for these to be circulated about the counselling that we're given. So really counselling about the success rates, counselling about the timescale for success, counselling about IVF funding, and their partner's fertility. Those are the big things I would do. Is there any role for sperm induction for primary infertility in Klinefelters? There is through microteasy. It's a very different, and we just published a meta-analysis in Human Reproduction Update looking at the potential role of sperm induction in this, although that's a different topic, which I'll be glad to talk about another date. But it's much more controversial giving sperm induction to men with primary testicular failure. What I'm talking about here is something that's been proven to work. Mohammed Malik, may I ask if there's a role of checking inhibin B and AM, etc.? Yes. So inhibin B is kind of, we have, it's a difficult marker to order in your hospital, but it's just another marker of testicular function, and it basically increases when you do sperm induction. Now, testicular volume also goes up, but the proof is in the pudding. You know, you're looking for sperm as well. So ultimately, does it really change management? I know of no evidence that it does, but it's quite a nice reassuring thing, a number that seems to go up, but I'm not sure it's necessary in a sperm induction cycle. How much of a contribution do other factors like smoking, poorly controlled diabetes, hypothyroidism make? Very good question, Julian. We don't know, and I think because of the lack of prospective data, we may never know about those. But what we are trying to do is collect a very large cohort to answer big things. But I'm not sure we're going to get reliable data collection about these factors, so I'm not sure we're going to get those. but hopefully I've highlighted in the talk the things intuitively that will make a difference. Bernard said, in terms of NHS waiting times, do you support general endocrinologists to prescribe HCG, or should patients be always referred? What I would do is I would take your own approach and speak to pharmacy and see, do I have the facilities to prescribe? Now, I know from colleagues at, say, Northwick Park that some of them are happy to start therapy, and then if things aren't going well, or there's an issue, or they need escalation, then they refer over, or you can refer at the start. But I would just make sure that you have the ability to prescribe it, because these are expensive and pharmacies sometimes say no. So, but it does need to come out of your budget rather than an individual funding request. Do we stop TRT altogether during sperm induction? Yes, you do. So the testosterone, you transition from giving them testosterone to getting them to make their testosterone. So it's like switching engines on a plane in midair. And literally it takes a few weeks for HCG to start working. And I always tell them that they may feel a bit of a bump on the road in terms of feeling a little bit lethargic until the test, but you will get them hopefully aiming for a mid-range testosterone in the teens. I think we're probably running over time, aren't we? Let me do this last one. Can low testosterone result in asthenospermia with an all sperm count? Low testosterone, basically what you've really asked is, can it reduce motility with a normal sperm count? I kind of see all the factors that you measure in a sperm count as different facets of the same thing. So basically, low testosterone can either cause oligospermia, so low count, asthenospermia, low motility, or teratospermia, a low morphology. So it can do all of them. They generally, if you've got a low enough testosterone, do all of them at the same time. I think I should call it there. That's all right. Fantastic.
So this is a common condition you're going to encounter in your antenatal clinic. My talk will be a little preamble about a bit of fetal and maternal thyroid physiology. I'm then going to talk about thyrotoxicosis, and then neonatal thyrotoxicosis. I'll then go on to hypothyroidism, a little bit about fertility and the thyroid, particular TPO antibodies, which you'll probably come across, postpartum thyroiditis, and iodine deficiency. So, first of all, the effects of poor thyroid control in pregnancy, and this is the reason we see that patients in our antenatal clinics, is that they affect pregnancy outcomes. Both of them cause miscarriage, both cause gestational hypertensive disorders, including preeclampsia. If you have undiagnosed thyrotoxicosis, you could potentially produce severe thyrotoxicosis, otherwise known as thyroid storm, and you can have a woman with undiagnosed thyrotoxicosis presenting with congestive heart failure. Hypothyroidism itself can, as a consequence of poorly controlled gestational hypertension, cause abruption of the placenta and postpartum hemorrhage. Now, with regard to the fetal thyroid, why do we have thyroid hormone replacement? There's no thyroid hormone production in the first trimester, and the fetal thyroid becomes fully formed at 12 weeks. So in a woman with an intact thyroid, the maternal T4 production increases by about 50% to compensate for that, because thyroid hormone is very important for neuro development. Thyroid hormone synthesis itself starts at 10 weeks and doesn't become fully functional until about 17 to 19 weeks. An adult or postpartum levels aren't actually reached until 36 weeks, but the fetal pituitary has some element of thyroid hormone resistance, which is why you get raised TSH at birth if you look at cord blood. one thing you will often find in your clinic is you'll be sent some thyroid function tests where there's a low TSH. Now, that you tend to get that in the first and second trimesters, and this is because of the similarity in molecular structure between HCG and certain pituitary hormones, such as TSH, FSH, and LH. Now, they all have basically the same alpha subunit, and it's the beta subunit that differs, although with HCG, it has a very similar structure to TSH. And this causes the situation of gestational thyrotoxicosis, which I'll talk about in due course. It's a transient phenomenon. It's mostly seen in the first trimester. The TSH normalizes within 3 weeks of the HCG coming down. And what will often happen is you are presented with a patient with hyperemesis, and you get a low TSH, and that's normally due to gestational thyrotoxicosis. But if they're very high levels of HCG, these tend to be found in things like hydatidiform mole, that's not meant to be cholangiocarcinoma, actually. Sorry, that was probably writing this at 1 o'clock in the morning. Twin pregnancy. And what you need to do at that point is distinguish between whether the patient's got Graves' disease or whether this patient has gestational thyrotoxicosis. How do you distinguish it? Well, nausea and vomiting are not really symptoms of Graves' disease. You would look at the past medical history. Have they had thyroid disease before? Do they have signs of Graves' disease, such as ophthalmopathy, a goiter? Is the free T3 raised? That tends to be more so in Graves' disease than gestational thyrotoxicosis, and you would also measure the TRAB to see whether that comes back as positive. What I normally do is, if there are no obvious signs of Graves' disease, then I would just repeat the TSH in 4 weeks before considering therapy, and that also gives you some time to get back your TRAB result. In the past, people used to use something called red cell transketolase, but this is not really available and probably not been validated beyond research conditions. So, with regard to TRAB measurements, and you have a patient with thyrotoxicosis or with previous Graves' disease, when should you be measuring it? Well, first of all, you should measure it in the first trimester, or if you wish to distinguish Graves' disease from gestational thyrotoxicosis. If it's positive, then you test again at 20 weeks. If it's positive, then you test again at 28 weeks. If at any point then they're negative, you don't need to test them again. If it's positive at 28 weeks, then you will need to consider that the fetus is at risk of thyrotoxicosis, and you may get neonatal thyrotoxicosis. And the reason for this is TRAB is an IgG, and as you know, IgG can cross the placenta and then can stimulate the thyroid. TPO antibody is also an IgG, but doesn't actually cause hypothyroidism in the fetus or the neonate. So you can reassure the woman with positive TPO antibodies that the child should be safe. Now, when it comes to treatment, we have, in the UK, carbimazole and propylthiouracil. In parts of Europe, and certainly in the USA, they use methimazole, which is an activated form of carbimazole, and put on the equivalent dosing. So 15 milligrams of methimazole is equivalent to about 20 milligrams of carbimazole. Now, both carbimazole and methimazole can cause very rare structural abnormalities, such as aplasia cutis, choanal and esophageal atresia, and VSD. We would therefore recommend that a woman with preconception Graves' disease is switched to PTU. But if you find a woman is already on carbimazole and finds that she's pregnant, then you should switch to PTU before the 10th week of gestation. The equivalent dosing of PTU to carbimazole is about 20:1. So 200 milligrams of PTU would be equivalent to 1 milligram of carbimazole. Sorry, to 10 milligrams of carbimazole. The reason we then switch to carbimazole for the rest of pregnancy is because of the rare but significant risks of hepatotoxicity associated with PTU. So what do you find? This is taken from pictures from the American Journal of Medical Genetics, 2005. I've provided the citation there. You tend to get chylomalatriasia, so you can see the eyes are closer together and the nose doesn't develop that well. You can see in that side profile. I haven't shown pictures of aplasia cutis because that's the thing we're traditionally been taught, but perhaps we don't know too much, see this as often. And that particular article was titled, subtitled "An Emerging Condition." So how do we treat thionides? Well, there are two treatment regimens. The more common one is the titration regimen, but you may also use block and replacement, which is often used in patients with thyroid eye disease, or if you don't wish to follow up as frequently. In pregnancy, however, only the titration regimen should be used. And usually, except in a very rare circumstance, which I will come to later, a block and replacement should not be used. And this is because of the differential transfer of thionamides and levothyroxine across the placenta. Thionamides cross far more readily than levothyroxine. And so, as you can imagine, this can then lead to fetal hypothyroidism and goiter if you use the block and replacement regimen. Now, because of the immunosuppressive effect of pregnancy, the dose usually decreases and often the drug can be withdrawn. Now, if prior to pregnancy, the TSH is normal, or the patient's on, say, just 10 milligrams of carbimazole, you could even consider stopping it there and then. But what you need to do is check the TSH and free T4 every 2 to 4 weeks, and every 2 weeks if you're considering changing either the drug itself or the dose of the drug. Now, the TSH will often be suppressed, partly because of HCG, but partly also because of the ongoing effects of the Graves, and therefore you can't really use that as a target. And so you would aim for the free T4. You don't measure free T3, and you try to keep that in the upper half of the normal range, at least until the 20th or week of gestation. Thionamides after pregnancy can be used, and they're not associated with any concern. PTU tends to be present in very negligible amounts in breast milk and far less than carbimazole is. But on the whole, if you've got patients on carbimazole less than 20 milligrams a day, it's not going to affect the baby. And so you can continue using that if it's easier, and especially given the fact that we are concerned about hepatotoxicity with PTU. The recommendation is that you measure the TSH at 6 to 8 weeks postpartum, because that is the time when you tend to get relapse of Graves' disease. And so in order to avoid women becoming thyrotoxic without treatment. Now, one thing that can happen, which we're concerned about, this is the reason we measure the TRAB, is because of fetal and neonatal thyrotoxicosis that tends to happen when you have a TRAB greater than 3 times the upper limit of normal. And what you would do at that point is monthly measurements of using Doppler studies of the umbilical fetal umbilical artery, and looking at from 26 to 28 weeks onwards fetal biometry, which your ultrasonographers will be aware of. One bedside test, if you can call it that, is to measure the heart rate of the fetus. If that's above 170 beats per minute, that gives an idea that it may be thyrotoxicosis. If the fetus has a goiter, that is important to establish because that can cause obstetric complications and you might not be able to have a vaginal delivery. How you treat it is by giving the mother carbimazole. Now, this is the one case where you might use a block and replacement regimen because the mother may well be in remission. Giving her thionamide, in this case carbimazole, will render her hypothyroid, and so that's when you would add in levothyroxine. Neonatal thyrotoxicosis is a risk in women with strongly positive GAD antibodies. Sorry, not GAD, with TRAB antibodies. And you would consider this if you have that and then postpartum the neonate is failing to thrive or is becoming jittery. You would have already, or you should have told the pediatricians of the risk of this so they can keep the child under review, and you check the child at delivery and 1 to 2 weeks afterwards with measurement of TSH. As with the rest of inherited maternal immunity, this should resolve within 6 weeks. However, you can treat it quite easily through thionamide therapy, and you would do this by treating the mom because then it would be going into the breast milk, and you would then resolve the situation, which is self-limiting in any case. Having dealt with thyrotoxicosis, I'd just like to move on to hypothyroidism. First of all, preconception, we should be aiming for a TSH of less than 2.5. If a woman has, with no history of thyroid disease, but for example, if they are undergoing fertility treatment, if their TSH is less than 4, that's fine. But if they are known to have thyroid disease, then you have to aim for a TSH of less than 2.5. Once the patient is pregnant, then you should increase the pre-gestation dose by about 25 to 30%, and then you adhere to trimester-specific TSH targets. And that is in the first trimester less than 2.5, and second and third trimesters less than 3. You would also aim for a higher range of free T4, as in the higher upper half of the normal range, as this is a secondary target, and also the rarer condition where you have women with pituitary hypothyroidism, you'd be using the free T4 in any case to guide treatment. Now, once delivery is occurred, you can go back to the pre-gestation dose of levothyroxine. However, some people suggest you wait about 2 weeks because of the changes in thyroid binding globulin. Now, the reason we increase we do all of this is because observational studies, this famous one from 1999, saw that school-aged children in women with poorly controlled thyroid hypothyroidism were found to have a reduced IQ. However, an RCT done by Lazarus in 2014 showed no difference. The only thing I would say about that is that this was in screen-detected women, and they didn't start the thyroxine until about 13 weeks. And as I've shown you before, the fetal thyroid is only just morphologically formed at 12 weeks, and fetal thyroid hormone production doesn't start till 10 weeks and doesn't reach capacity until about 19 weeks. So therefore, one would, the observational study would have taken into account women with poor thyroid hormone control in the first trimester. One thing you will be asked about nowadays, especially from often fertility clinics, check this, even though there's no evidence for it, in terms of what you can do about it, is that TPO antibody comes back positive. TPO antibody positivity is associated with reduced fertility in terms of increased miscarriage and preterm birth. And it may well be related to vitamin D status, but there's not, you don't necessarily treat it with vitamin D, although vitamin D replete status is associated with increased live births. But I wouldn't take those patients on into your clinic, because really you're not going to be doing anything specific in an endocrine clinic. Really what your main focus should be is if that patient has hypothyroidism, is to ensure that they have optimized therapy for their hypothyroidism, but also to be aware that it does predict future hypothyroidism. A study done in 2019 which is a randomized control trial, showed no evidence for the treatment of levothyroxine of women with normal thyroid function and TPO antibody positive status. But often what you get is fertility clinics asking patients to be referred to endocrine clinics when they have completely normal thyroid function but have positive TPO antibodies. Now, we are often confronted with this, which is that often being it affects 5 to 10% of pregnancies, but that's quite a significant workload, is postpartum thyroiditis. This usually tends to occur about 2 to 6 months after delivery, but can occur up to 12 months after delivery. Now, one thing you need to distinguish postpartum thyroiditis from is relapse of Graves' disease. Postpartum thyroiditis tends to occur within the first 3 months, whereas Graves' disease tends to occur after about 6 months. Obviously, if a woman is known to have Graves' disease, as I've said before in a previous slide, you do need to check at about 6 to 8 weeks to see whether or not they have relapsed. It's a postpartum thyroiditis is a destructive thyroiditis, and so, as you would expect, if you do thyroid Doppler ultrasound, you get hypoechogenicity, whereas in Graves' disease, you get hyperechoic pictures. You can use a nuclear medicine scan, but the mother should be advised to discard breast milk for 3 days after the scan. Again, as with a destructive thyroiditis, you get reduced tracer uptake. What tends to happen, about, if you split them into thirds, is that about a third of patients have the classical form, which I will talk about. A third of them have isolated thyrotoxicosis, and a third of them have isolated hypothyroidism. The classic phase is similar to other cases of thyroiditis, in that you have a thyrotoxic phase followed by a hypothyroid phase and then recovery. During the hypothyroid phase, you may wish to, you can use levothyroxine, because a significant proportion, about half of them, will be permanently hypothyroid, especially if they have TPO antibody positivity. You tend not to use thionamides in the thyrotoxic phase, and you just use symptomatic relief using beta blockers. Postpartum thyroiditis tends to be more common if you have other autoimmune conditions like type 1 diabetes and SLE. And finally, I just want to talk about iodine deficiency. This has been a target for the World Health Organization, which recommends that you have 150 micrograms of iodine per day. Many populations are iodine deficient or have mild iodine deficiency as opposed to severe iodine deficiency. It is associated with reduced brain development in the first trimester. It's more an issue in the general population of goiter, of producing goiter. There was a study done by Mark Vanderpump, I think in 2011, looked at school girls in northwest London and found that there was a mild to moderate iodine deficiency. If you don't drink milk, which is a primary source of iodine, or you have, for example, if you have lactose intolerance, then you won't get that. And iodine is present in sea salt or sea fish, as opposed to river fish. But you have to have counsel women that of not having too much sea fish because of the worries about mercury poisoning, especially in farmed salmon. So you could ask them to just use iodized salt, which is readily available. Now, the problem is, how do you measure it? Well, you don't. What you have to get is a 24-hour urine collection, which is fine on a population basis, but there's a large amount of variability and difficulty in actually storing and measuring the iodine. It's not standardized. On a population level, you aim for 150 to 249 micrograms per liter, but that doesn't translate to the individual level. It doesn't necessarily accord with the thyroid status of the patient, and therefore we don't measure it. So apart from telling women to increase their iodine intake, because this is important for also because of the demands of pregnancy and breast milk production on the woman, it can render the woman iodine deficient if they're already at borderline an iodine status. I've included a couple of things you might wish to read. One, they're both from 2023. One is in draft, but you can still read it. The previous guidelines from the European Thyroid Association from 2014 from Lazarus, but I haven't included those because there's a new guideline coming out shortly from the Royal College of Obstetricians and Gynecologists. I found this first citation very useful for just general information about the thyroid in mother and fetus, as well as iodine status. Okay, thank you for listening.
I think there are lots of questions in the chat.
Are there? Okay, brilliant. I can't see anything.
Sorry, no, it's fine.
Thanks.
I think it starts from here.
Okay, so first question from Shona Jacobsberg is, if TRAB is positive in first, what's the value of testing at 20 weeks and one at waiting for 28 weeks and save the cost? Well, those are the recommendations. I don't write them, but I can see your point. But you test it again basically because you might have cleared it at 20 weeks, and previously you would only test at 28 to 30 weeks, but the recommendations have come earlier, presumably because you can get fetal thyrotoxicosis, and you would need to think about measuring that. What is the maximum dose of carbimazole in each trimester? There are no trimester-specific doses or preconception. You go for the lowest dose possible. No, the next question is Nina Kamran, CBZ 1 milligrams, 10 milligrams. The latest guidelines suggest 20 to 1 rather than 10 to 1. I must admit, I've used 10 to 1 before, but I've put on what the latest stuff is saying, the RCOG draft. Presumably the effects of beta HCG on TSH levels relevant for women on levothyroxine for post-total thyroidectomy. Before I carry on about that, there was one thing I meant to write, and that is that with regard to TRAB antibodies, if a woman has had subtotal thyroidectomy or has had radioiodine, you should still measure the TRAB status and not assume that just because they're hypothyroid, then you don't need to measure it again. With regards to the TSH, what I tend to do is if you have, say, for example, in the second trimester, the TSH is around 3, because of the effect of beta-HCG, so reducing the TSH level, I would consider that may suggest that they're undertreated. So therefore, I may increase the dose of levothyroxine at that point to get it well below 3. I presume that's what you're asking. What is the place of thyroxine isolated hypothyroxanemia in pregnancy? It's a very good question. I think if it's the first trimester, first and second trimesters, I would consider treating with levothyroxine, basically because I can't rely on the TSH to guide me. Subclinical hypo patient seeking fertility, any target TSH level, yes, it should go for a TSH less than 2.5. Any reason why there is no iodine fortified salt in this country? It's fairly common in Europe. There is fortified salt in this country. I mean, I think the company is called Cerebos. It's got a brown and yellow design. It's found in all supermarkets. If you're talking about why food isn't fortified, that's down to, I guess, what you're trying to treat. You can actually cause thyrotoxicosis in the population. For example, in Tasmania, when they fortified their food, they had an uptick in thyrotoxicosis cases. I think in Europe it was partly, I mean, the World Health Organization's drive is because of brain development in countries that are lacking iodine. The latest world map shows a significant reduction in the countries that have iodine deficiency, and sadly, they tend to be the countries where there are wars going on. This is a public health directive. What would be the lowest TSH? Would you consider pregnancy to be normal? Is there any role for treating maternal subclinical hypopositive thyroid antibodies? With regard to the first question, if the patient doesn't, so in the first question, let me just deal with what I've said before. With hypothyroidism, if you're worried about, we don't normally screen for well, we do screen for hypothyroidism, but if the TSH, they don't have pre-existing thyroid disease, TSH less than 4 is probably fine. With regard to the lowest TSH, I think you would have to consider any TSH in the first and second trimesters, which is low, that it may be a cause or due to their HCG, and at that point you're trying to just see whether or not this is Graves' disease or gestational thyrotoxicosis. And if you've got positive TRAB antibodies and they've got subclinical hypothyroidism, I would treat them. And subclinical hypothyroidism is they've got a reduced TSH but normal free thyroid hormones. The only caveat being that if the free thyroid hormone, that's the free T4, is in the upper half of the normal range, I wouldn't treat them, because what we're aiming for is a free T4 in the upper half of the normal range. Just another point, there's no role for using T3 or desiccated thyroid, and it's counseled against in women with hypothyroidism. Any other questions? Oh, there's 8 new messages. Sorry. Right, okay, sorry, I didn't see these. David Hope, thank you. How often do you see patients TRAB, positive thyroid probe, which remit in later stages of pregnancy? I think the majority of them remit in the latter stages of pregnancy. What is a concern is those who don't. I've had 2 patients recently whose TRAB never dropped below 100 international units, and in those we were looking for fetal and neonatal thyrotoxicosis. So as I said, we were looking at the fetal heart rate, looking at the fetal thyroid, and warning the pediatricians of impending problems. Any comments on recommending definite treatment of women looking to get pregnant at 6, 12, 18 versus 24 months? RI versus thyroidectomy. So if you have radioiodine, you shouldn't get pregnant for six months. If a woman is known to have Graves' disease, I think the definitive treatment would be thyroidectomy. The problem with that is that you could render them hypoparathyroid, and that has its own problems. Is there any data about COVID-related thyroid autoimmunity and fertility? Honest answer is I don't know. I haven't looked at that. What would be your approach on patients on liothyronine during pregnancy if they're already on? Would you continue the drug? I hope I've answered that. What I would do with any patient with liothyronine and wanting to go into liothyronine is I refuse to see them and I refer them to Professor Miran's excellent clinic, for which you'll be getting a sainthood. Astrid said there's no sound. Can you people actually? Okay, brilliant. Okay. I hope you heard the bit about Professor Miran's excellent liothyronine withdrawal clinic. How can we help to prevent fetal thyrotoxicosis if TRAB is positive at 20, or suggest, as you said, mother's not thyrotoxic, would you still treat the mother? Yeah, so I would treat the mother, and that's the rare condition where you use a block and replacement regimen. Because the carbimazole would get across the placenta, and you would give the thyroxine to prevent the mum becoming hypothyroid. Can you quantify the risk of thyroid-related birth defects of PTU and carbimazole? I can. It's extremely rare in PTU, and to be honest, it's pretty rare in carbimazole. So I would counsel the woman, even if they're, for example, if they're beyond 10 weeks and they're still on carbimazole, that it's highly unlikely. It's quite subtle. I can't give you the actual numbers off the top of my head, but they are in the RCOG document, so you should be able to find it in there. I think it's less than 0.01% of births. If patient is euthyroid, normal TSH, but greater than 2 per TPA positive, a history of miscarriage, what's your threshold for levothyroxine? So the study I showed you, I think there's no real reason to give the levothyroxine at that point, or I wouldn't. If to make the patient feel better, you might want to give them less than 2.5, but there's no real evidence for it if they're euthyroid. There is just a fetal goiter in those with TRA positive, in those women who have Graves' disease treated in the past but are now euthyroid, not in treatment, but when do they need an extra fetal scan? I hope I've answered that, because unfortunately I didn't put it on my talk, but I did put it in when I was talking afterwards. Yes, if they're TRAB positive, then I would do fetal scans as stated at 26 to 28 weeks if they're still TRAB positive at that point. So if they've had Graves' disease treated, even if it's total thyroidectomy. In the past, we used to do subtotal thyroidectomy. As a medical student, I sat in on one of those, but now that's gone out the window really, but there still may be some historical cases. Any woman with previous Graves' disease, I would check for TRAB antibodies at in the first trimester, 20 weeks, 28 weeks, and if positive at 28 weeks, I would be looking for doing fetal scans. Any role of steroids in pregnancy, thyrotoxicosis not responding to? I don't know of any role for that, unless the patient is presenting with thyroid storm. Euthyroid patient with positive TRAB going to IVF, would you recommend treating or just monitoring? I would, with positive TRAB, let's just to delineate this from TPO antibodies, I would not treat, I would just monitor. Is there any evidence, is there any difference in the acute management of thyroid for non-pregnant patients? I wouldn't have thought so. I mean, your primary goal there is to protect the patient, because if the mother's physiological status tanks, then obviously the fetal outcome is going to be also very poor. So you would have to have close liaison with the obstetric team with regard to potential early delivery, but the use of hydrocortisone, you would have to discuss with them whether that is sufficient to mature the fetal lungs. And the other things would be, you'd be using PTU over carbimazole because it reduces the conversion to T3, but you've got to remember that there's deiodination at the placental level in any case, so that in some ways the fetus is protected from the mother's thyroid levels. So your primary goal, as far as I'm concerned, I don't know if the other endocrinologists would like to add anything, would be really the mom, and the fetuses or the baby's chances of survival will really depend on where we are at the point in pregnancy and early delivery.
Thank you so much.
Oh, hang on. Which beta blocker is preferred for how long trimester for starting help with adrenergic symptoms? I think the one that we use is propranolol. You've got to remember, this is if you're thinking of gestational thyrotoxicosis, this is a self-limiting condition, so it's unlikely to cause major problems, and the benefits outweigh the risks. Same goes for if you have the thyrotoxic phase or isolated thyrotoxicosis, thyrotoxic presentation in postpartum thyroiditis, it's unlikely to cause much harm to the baby and breastfeeding.
So much. That's excellent.
Thank you.
Thank you very much. So when I said thank you very much, you can't hear me, can you? So your last one just turned off. Oh, it's turned off here.
No, but
No,
then we
you
should.
get on there.
Oh, you're very right, because
Yeah.
you muted for Chana's talk.
Just click escape. Just click on there. That's it.
Fine, Kate, sit here. Yeah, she's on. She's on.
I'm going to say Korean costume.
Yeah, it's okay,
What I'll do is I'll
Thank
tweak
you, sir.
it and then I'll send it back to you, and then you can share it
Thank you so much.
with
Thanks.
questions. Okay.
Thank you. The next talk that we would do is we just wanted to talk about a current ongoing study that's going national-wide study, and if anyone's interested, it would be really useful if they could come catch me or Kate or Prof. Mirren, and we could talk about other centers joining our study. Let me just share my slide. Okay, so the study that we're going to talk about is hydrocortisone versus prednisolone in adrenal insufficiency disease, or HYPER-8 study. The chief investigator is Professor Karim Mirren, and it is currently recruiting around, we have ethics up to 500 patients. So basically, adrenal insufficiency disease is either due to primary adrenal failure where there's no cortisol production, or pituitary or hypothalamic disease, which is called as secondary adrenal insufficiency. In these disease, there is we need to replace steroids, and the ideal steroid replacement strategy is not known, but aims to mimic the normal daytime cortisol profile. It is clear that health outcomes for these patient cohorts are poor when compared to the general population with regards to morbidity and mortality. Patients with adrenal insufficiency have a significantly shorter lifespan and increased morbidity with increased risk of infections, cardiovascular disease, osteoporosis, and osteopenia that's associated with reduced quality of life. In the UK, the current guideline recommends hydrocortisone, and prednisolone is also listed as an alternative. The most common regimen in clinical practices uses the dose of hydrocortisone of 10 milligram on waking, 5 milligram at lunchtime, and 5 milligram in the afternoon. The cost of 20 milligram daily of hydrocortisone is around £157 for a 30-day supply. Once daily prednisolone is another regimen in clinical use and now prescribed at less than 5 milligram daily. It has a longer duration of action and a smoother pharmacokinetic profile compared to hydrocortisone, and it is much more cost effective. Prednisolone has previously been less commonly used due to perceived concerns regarding loss of bone mineral density leading to osteoporosis, increased insulin resistance, and rise of blood pressure. This belief is perhaps driven by the fact that most of the clinicians encounter prednisolone in the context of treatment for asthma, rheumatoid arthritis, etc., where far higher doses of prednisolone are used. So prednisolone is more popular at Imperial following the introduction of prednisolone assay a couple of years ago. Hence, the study is therefore aims to compare the standard regimens of the hydrocortisone against a very low dose prednisolone in the treatment of adrenal insufficiencies. We look at the bone turnover by looking at P1NP, parathyroid hormone, bone profile, vitamin D, and urine NTX. This is the primary endpoint. And the secondary endpoints also include cardiovascular risks by looking at weight, blood pressure, heart rate, waist hip circumferences, as well as lipid profile and high sensitivity CRP. We also look at the glycemic control by checking their HbA1c and looking at the safety by assessing the patients and asking them whether they've had any reported symptoms of steroid deficiency or excess. We also check their well-being by assessing customized subjective health questionnaires. Sorry, I can't see some on the screen. Okay, so the study design, the patients need to be stable on either prednisolone or hydrocortisone for at least 4 months before they're seen by a clinician, and they're then switched to either prednisolone or hydrocortisone. And they have to stay on it at least for 4 months before we do further assessment. The study is a data collection study, so we opportunistically pick up patient and switch them from either prednisolone, hydrocortisone to the other medication. It is designed to minimize impact of study on patient and center. So the patient at least have to stay on each medication for 4 months and been stable on it before we collect data. As mentioned previously, we have ethics for up to 500 patients to be recruited. Current active sites include Imperial, Leicester, Kettering, Hull, Coventry, and Leeds. There are many more pending sites, and they're just awaiting R&D to approve, and we would start studies on those sites as well. And so just to go back to the study design. So initially we identified the adrenal insufficiency patient and give them a patient information sheet. And if the patient wants to be a part of the study, they're consented. Once consented, their first visit, they have to be stable on the medication for 4 months. We would then record their blood pressure, pulse, height, weight, waist and hip circumference, and do the necessary blood tests. Patient is then to complete a questionnaire at the end of the visit, and we repeat the same thing on the second visit. The inclusion criteria include, it can be patients anywhere between 18 to 85 years old, be male or female. The patient needs to be diagnosed with adrenal insufficiency for at least over 6 months, according to a standardized diagnostic criteria. They have to be stable on hydrocortisone replacement or prednisolone replacement, and the dose has to be stable for at least 4 months. The participants taking other hormone replacements, such as like levothyroxine, testosterone, or growth hormone for secondary adrenal insufficiency, are accepted, providing that their replacement doses have also not been altered for the last 3 months. Participants who are able and willing to give written informed consent to participate in the study are also included. So exclusion criteria would exclude patients that are not able to give informed consent, and patients who are pregnant or patients using the combined oral contraceptive pill.
So I'm Kate, I'm one of the other registrars and clinical fellows working on this study. Can we just give a really nice overview of it? It's basically a data collection study. Patients are switched clinically to either prednisolone from hydrocortisone or vice versa. And it's very, very simple. This is an example of the pro forma that we use and that we send to the other sites who are currently recruited. It's a case of doing your normal clinical sort of consultation with the patient, just having basic information about their general health today, their past medical history, their current medications, and then just the extra things that we do are the weights usually done by the nursing staff before they even come into the clinic room, but their waist and their hip circumference, a pregnancy test if they're female and of childbearing age, and then we just do some baseline blood tests. And I know a lot of centres don't do bone markers such as P1NP and urinary NTX. At Imperial, this is standard practice, but it's not a problem if your centre doesn't. We have lots of centres who aren't doing it, but the idea is just to collect as much information as possible on these patients prior to switching and then post-switching after they've been on the other treatment for at least 4 months. And we just, because we're collecting some extra information in terms of the questionnaire, we just consent the patient. So yeah, very straightforward. We see the patient clinically just normally, and we do some baseline bloods that get done in phlebotomy. We get a urine sample if your lab does that urinary NTX, and they complete it. It's literally 3-minute questionnaire online. And then we give them the prescription for the prednisolone if they're switching from hydrocortisone, and just counsel them in terms of dosing and how best to switch. We usually find patients do better if they start at a slightly higher dose. So at Imperial, the aim of the study is to use 2 to 4 milligrams of prednisolone, so very low dose. And we tend to start at a slightly higher dose for a week and then get them to alternate for a few more days and then come down to a lower dose if they feel well. And then they have a normal follow-up appointment as they would do clinically. And then the plan would be to just repeat everything at that next appointment. And we've had a sort of an interim analysis recently where we just looked at some of the patients who'd completed both visits at Imperial. So we have more than 23 who have joined the study, but of those who've completed both visits, we've got about 23 patients. So there's 12 who've gone from hydrocortisone to pred, and 11 who've gone from pred to hydrocortisone. Of those who have switched from hydrocortisone to prednisolone, the mean baseline weight is 80.2 kilograms, with a difference of minus 2.6 when they then switched to prednisolone. And this was statistically significant. And then going the other way, those going from prednisolone to hydrocortisone have actually shown to gain weight. We've obviously got quite small numbers, but it seems to be a trend that looking at other sites, even though there are small numbers, it's a trend that seems to be occurring. We obviously need a lot more numbers to show significance. So obviously looking for more centres, and we've got a number of centres who are ongoing at the moment. And just some thoughts about why the weight loss might be occurring. Feeling is it could be due to less glucocorticoid exposure, because prednisolone mimics a more physiological profile. We avoid supraphysiological levels of cortisol later in the day when we know people are more sensitive to cortisol. The study's shown that once daily low dose prednisolone appears to be safe in terms of, you know, people are well on it, and there isn't an increase of adrenal crises. Sick day rules still stay the same, so when we see patients we cancel them the same way as we would if they're on hydrocortisone. So yes, our very preliminary interim results from the study suggest that it may have a beneficial effect on weight, but we obviously need far larger numbers, and to also look at all the other outcomes in terms of cardiovascular health, bone profiles, glycemia, etc., before we can have a better idea. We also have a randomized controlled trial that's finished recruiting, which is a much more controlled scenario, which is also a crossover study where patients are on both drugs, and the results for that will hopefully come out in the next, I would say, 8 to 9 months, possibly a year, once we finish the last patient in the autumn. And I think Coventry are online, who are just going to show some of their interim results as well. I don't know whether Bianca's able to. Amazing.
Hi, good morning.
Morning.
I'm going to share my screen.
We can see your screen, Bianca.
Yes. So I'm Bianca, a clinical fellow at Coventry, where we are also conducting the HyperAid study. And until now, we have recruited in the trial 14 participants, out of which 7 females, and from them 8 attended their follow-up appointments. That was approximately 4 months after switching from hydrocortisone to prednisolone. 7 out of the 8 patients had secondary adrenal insufficiency, and 3 were females. Their mean age was 58 plus minus 12 years. The youngest 38, oldest 77. We have conducted some pair t-test on all the parameters that we looked at, and we have noticed no changes from baseline to follow-up, but this is probably due to the low number of patients that we have included in the analysis. However, we could see a decrease in trend in weight from 97.9 to 96.4, in waist circumference from 107 to 105. There were also decreases in systolic, diastolic blood pressure, fasting glucose. And what was statistically significant was the decrease in monocytes. Looking at the lipid profile, there were no changes there either. When we have compared males versus females, we have noticed a decrease, a statistically significant decrease in waist circumference in females from 119 to 115 centimeters. But we had only 3 females included in the analysis. So these are the results that we've got so far. But what is to note is that none of the patients wanted to switch back from to hydrocortisone when given the choice to do so.
Thank you. I don't know if anyone's got any questions. We should get the next talk lined up if Bijal's ready. But whilst you're doing that, can I ask if anyone's got any questions? What I would be very keen is if you are thinking of switching patients over, could you not switch until they're being studied? Because it's a shame to get all this people switching over and not having evidence that we're doing the right thing. Notice that with the small numbers, there's a risk of a type 1 error, there's a risk of a type 2 error. So we actually don't know if it is beneficial in that complementary cohort. It might be. It's tempting to look at those just non-significant results, but be careful, everybody, about analyzing statistics. So we definitely need a higher N, and the higher N might show no difference, or it might show a significant difference. Wherever it is, we need them to be studied. There's some questions here. Yes, most of them, that's right, because of course, publicly, all their patients are hydrocortisone. Whereas here, a lot of patients are on pred, and so we can switch them to hydrocortisone. But if all patients are on hydrocortisone to start with, then of course they're going to go in one direction. Julian's got a good question. We don't use it anymore. We used it initially to work out what we think the right doses are, and it's between 2 and 4 milligrams. So we don't use it much. We use it sometimes to demonstrate to patients that they're safe. When they're worried about it, but we're getting more confident with it as we've gone on.
Green, can I ask a couple of questions?
Yes, and there's a question from conduct. Yes, go ahead.
So one question is, we have hydrocortisone assays to guide us. How readily are prednisolone assays available? And the other question is not related to Addison's, but to congenital adrenal hyperplasia. What do you see as of the role of prednisolone in that particular case, and how would you use it?
Okay, so first of all, the assay. The assay is basically the same in terms of availability, although it's done here. So Charing Cross can do it for anybody. It's not an assay finder, so you're allowed to, if you ask for a prednisolone assay, it'll be done here and sent back to you in the same way as a cortisol assay might, although that might be done locally, of course. So it's available to anybody in the UK. And so you don't need the pred assay to answer Stu's question. The second question was about CAH. So that's a long talk, can I say? But essentially, I'm moving patients to prednisolone once daily after they have finished having their family. Before then, it's a complicated area. We're using a mixture of hydrocortisone and prednisolone, depending on the patient and what they want, and their androgens and their symptoms and their potential for fertility. So that's a very long question, I'm afraid. Maybe we should do a whole session on it at some point. We're not recruiting 70 patients, no, Connor. These are for patients who are stable on one drug or the other for several months, and then see if the other one is better or worse. And the question from Dr. Iftika is, I think it's ease of use. Well, that's why we need a blind study. So there's another study going on that's double blind that will answer that question. But I think the real reason is ease of use. Maybe they feel better as well. Okay, do you want to share your screen, Bijal?
Hi, everyone. Can everyone hear me? Great. So I'm Bijal. I'm one of the research registrars, and today I will be talking to you about functional hypothalamic amenorrhea. And actually, I thought it would be a good idea to actually go through some of the cases that have actually entered our research study. So we're just going to jump straight in with our first clinical case. So this is a 23-year-old female who underwent menarche at the age of 16. And this is slightly later than the sort of average age at around 12 to 14 years. However, she progressed through puberty normally and had regular periods thereafter. 2 years later, she developed amenorrhea. And at that time, she had significant weight loss, around 12 kilograms over 6 months. And this was associated with a reduction in food intake, as well as exercising around 7 hours a week. And this was particularly doing cardio-related exercises. She denied having any sort of psychological stress, mood, or sleep disturbances. And at the time, her GP had started the combined oral contraceptive pill, but she decided to discontinue this a year later, and still she had no resumption in menses. So looking at other causes of potential amenorrhea, she had no headache, visual disturbance, or galactorrhea to suggest a hypothalamic or pituitary issue. She had no thyroid symptoms, androgen excess, or hyperinsulinism, and she had no stigmata of Cushing's or acromegaly. She had no relevant past medical history, including any history of fractures or eating disorders, and she wasn't on any medications. In particular, it's important to look out for antipsychotics, antidepressants, or opioids, as these can interfere with menstrual cycles. On examination, she was cool, her blood pressure was stable, and she was bradycardic at around heart rate of 46. Her BMI was in the underweight reference range with a BMI of 18.81 kilograms per meter squared. So at this stage, I just wanted to ask everyone, with the information that you have so far, what is the most likely diagnosis? Do you think she has hypogonadotrophic hypogonadism, anorexia nervosa, female athlete triad, idiopathic hypothalamic amenorrhea, or weight loss related FHA?
Right, we need 80 votes, okay? Can everyone please vote?
Okay, I think,
You'll need to reveal the results because
Yeah.
no one can see them yet.
yeah, I'll end the poll now. Okay, great. So it looks like most people have gone for choice 5, which is what I had gone with 2. And I'll go through each of the sort of different causes as we progress through this lecture. So just to remind everyone of the hypothalamic pituitary ovarian axis and its importance in being central for reproductive function. And as we're all aware, you have GnRH, which is produced in the hypothalamus, that then enters the hypophyseal portal circulation, where it acts on pituitary gonadotropes to stimulate the release of LH and FSH. This then travels downstream in the circulation to female gonads, the ovaries, to produce estradiol. Now, in FHA, this is aberrant, and you actually get abnormal signaling within the hypothalamus, which essentially suppresses this HPO axis, and you get cessation of ovulation and menstruation. But importantly, this diagnosis has to be made in the absence of a structural lesion or any organic pathology. And actually, FHA represents around 30% of cases of women with secondary amenorrhea, and can present up to 30% of women with primary amenorrhea. So a growing significant problem. Now, I thought it would be a good idea to also sort of cover sort of your degrees or different levels of menstrual status, ranging from one spectrum where you get amenorrhea, and this is typically women who have absent periods for 3 months, and this is usually in women who previously have had normal periods, or in women who have had absent of periods for 6 months if they previously had oligomenorrhea. And you can appreciate they'll have no bleeding and a very thin endometrium. The next phase is what we sort of call this subclinical menstrual dysfunction. and it's sort of made up of two areas, the luteal phase defect and an ovulatory eumenorrhea. So luteal phase defect briefly is essentially when women have longer menstrual cycles and they have a longer follicular phase with a shorter luteal phase, and this is because they have progesterone deficiency, and so essentially their period comes at an earlier time. As you progress on, some women can actually have regular spotting every month. However, their estradiol levels haven't reached a significant threshold to actually induce ovulation. And then again, at the other end of the spectrum, you know, healthy women who have both regular periods as well as can ovulate. So it's really important in clinic to try and identify where the woman lies. So in terms of like what causes FHA, we know that a low body weight, excessive exercise, as well as stress can cause FHA. And actually, importantly, these all can overlap. And this is when you get sort of different subtypes. So on the left here, we have the female athlete triad. And this is typically when a woman has an energy deficit. 69% of these women have amenorrhea, as well as osteoporosis. Another sort of feature is women who have anorexia nervosa, which is a eating disorder in which 89% have amenorrhea. Again, it's characterized by an energy deficit. I will like to note that at this point, BMI used to previously be part of the DSM-5 criteria. However, that's no longer required. But they do say a BMI of less than 17.5 is considered moderate to severe anorexia. And typically these women will have a disturbed self-body image, a fear of weight gain, and this sort of behavior to have a perfectionist sort of attitude in a social setting. Now, there are other factors that play in the sort of physiology of FHA, and this includes women who have heterozygous variants in certain genes that affect GnRH neuron migration and development. And so, you know, any of these sort of variants can predispose them. Okay, so back to our case with the 23-year-old lady. So we then assessed her reproductive hormone levels. And as you can see, we confirmed hypoestrogenism as her estradiol was less than 100. And she had low/inappropriately normal gonadotropins. Now, I just want to emphasize at this point that actually LH is typically low, whereas FSH is still preserved. And this is really because we know that as GnRH pulses are deficient and slow, you tend to secrete more FSH versus LH, which is what we're seeing here as well. And here at the bottom is just some data from our study. Here we have sort of sampling that we've done for blood every 10 minutes for 8 hours. And on the y-axis, we have our LH levels in red and FSH levels in blue. And here you can appreciate that in a healthy woman, the gonadotropin levels are much higher, and LH is, you know, nicely pulsatile. Whereas in FHA, in this participant, you can appreciate gonadotropins were much, much lower, and actually there was complete loss of pulsatile secretion of LH. Okay, so once we've sort of confirmed that the reproductive axis is suppressed, it's always important to try and ensure we exclude other causes of amenorrhea, as FHA is a diagnosis of exclusion. And so her pregnancy test was negative, her pituitary profile was preserved, and looking at her androgen levels, they were within the normal range. Her AMH, so that's anti-Müllerian hormone, was 40, and that's not typically consistent with PCOS. She then was given a progesterone challenge test, and normally we do that to see if there's any sort of outflow tract abnormalities. And normally women, if they bleed, it points towards having a central cause of amenorrhea. However, up to 60% of women with FHA actually don't bleed on a progesterone withdrawal test. And the reason for this is because they have chronically low exposure to estrogen, and their endometrial thickness, as seen in our case on ultrasound, is very thin at 1.4 millimeters. Usually we say less than 1.5, women will not tend to bleed. Interestingly, on her ultrasound, she also had polycystic ovarian morphology. As part of her workup, it's also important to look at bone health. And usually we look at Z scores on a DEXA scan in women who are less than 30 years, i.e. women who've not reached their peak sort of bone mass. And her range essentially suggested that she was still within the reference range for her age. So next question, which of the following is not typically found in FHA? Okay, so it looks like most of you went with B, which is what I went with as well. And I'll briefly go on to explain the other characteristics. So in FHA, apart from suppression of the reproductive axes, there are other features and other endocrine axes involved. If we start at the top here, women typically have low T4 and T3 with a preserved TSH. And the reason for this is women have a low energy availability and a reduced resting energy expenditure, and therefore have a suppressed thyroid axis as well. Women with FHA can also show growth hormone resistance with high growth hormone levels and low IGF-1. And this is thought to be due to impaired growth hormone receptor activity at the liver. And furthermore, a low IGF-1 can also mean that they're at high risk of having reduced bone mineral density as well. Women with FHA can also have reduced androgen levels, and both testosterone and androstenedione have been shown to be reduced in FHA compared to controls. Now, cortisol is typically raised in FHA because it's a state of stress, and you get activation of the HP adrenal axes. And so at baseline, cortisol levels are much higher compared to controls. However, following a CRH stimulation test, cortisol levels are actually reduced. And the reason for this is that we know that CRH actually sort of dampens GnRH pulses, and therefore in women with GnRH deficiency who have FHA, you would expect a blunted response. Okay, so as we saw earlier in the questions as well, there was one of the features that the lady had was polycystic ovarian morphology. And actually, we know that there is significant overlap with PCOS. We know that 86% of women who present with amenorrhea or oligomenorrhea can actually meet diagnostic criteria for both FHA and PCOS. Also, 1 in 5 women, including healthy women, can actually have polycystic ovarian morphology on ultrasound, which means that, using PCOM as a specific individual criteria is not that discriminatory. Furthermore, 17% of women with FHA have hyperandrogenism, and 33% can actually have high AMH levels, like greater than 41 picomoles per liter. And I know that the new sort of PCOS guideline has looked at using AMH, but there is this overlap. And interestingly, actually women can have both conditions at the same time. And studies have shown that 1 in 12 can actually develop PCOS on menstrual recovery. And actually those women tend to have higher androgens and higher AMH levels at baseline. So it's just something to think about in clinic. So our research team recently wrote a review to see how we can differentiate FHA from PCOS using different parameters. And essentially, we found that BMI was a good predictor. And here is a figure. So the x-axis you have BMI, and the y-axis is the percentage of cases with either PCOS in green or FHA in blue. And you can see that at a BMI of 21.2 or lower, the number of FSH cases or percentage of FHA is much greater compared to PCOS. Okay, and at this level, there was 100% sensitivity and 88.9% specificity. Looking at other parameters that would potentially be useful in clinic, again, LH at a cutoff of 5.36 or lower was able to differentiate FHA from PCOS. Similarly, AMH, a level of 41.3, helped to discriminate FHA from PCOS. And looking at total testosterone, a cutoff of 1.26 also identified FHA over PCOS. Again, you can look at our paper to see more of this in detail. Okay, so we have our next case, which is a 29-year-old female who underwent menarche at the age of 14, progressed through puberty normally and had regular periods. 10 years later, she developed amenorrhea. She had no weight loss at the time, but she exercised around 4 hours a week, mainly doing cardio, yoga, Pilates. She had no sort of psychological stress or sleep disturbances. She had no sort of symptoms to suggest another cause of her amenorrhea, no relevant past medical history or medication history. On examination, she actually had a very lean, muscular physique and was bradycardic. Her BMI was considered to be in the normal range, which was 24 kilograms per meter squared. So again, we measured her reproductive hormone levels and confirmed that she had hypoestrogenism with low or inappropriately normal gonadotropins. And again, data from our study showed that when we were sampling her blood every 10 minutes for 8 hours and measuring LH in red and FSH in blue, that although she wasn't completely flat, you can appreciate that, you know, her LH pulse amplitude wasn't quite like what you would see in a healthy person. Okay, so a bit more erratic. Again, we sort of excluded other causes of amenorrhea. She didn't have any signs of hyperandrogenism. Ultrasound was normal, but her DEXA score showed that actually within the lumbar region, she had a score of -2.1, and a Z score greater than -2 suggests that they have reduced bone mineral density below the average age for sex and ethnicity. So, what is the most likely diagnosis? And hopefully, if everyone's been following or paying attention, you might be able to get this one. And it is sort of a trick question. I had actually classed her as a female athlete triad because she did have amenorrhea. She did have an energy deficit. So even though her BMI was, you know, not in the underweight range, she was probably having an increased energy expenditure, which was causing that energy deficit. And obviously she had osteoporosis according to a DEXA scan. Okay, so in this patient, what treatment will you initiate? Estrogen and oral progesterone. But actually, you know, all of these options could have been viable. The reason why advice on reducing exercise levels wasn't the most likely, because remember, at this stage, she's already had 5 years of amenorrhea, and her bone scan is showing that she's got osteoporosis. So actually, you know, there is a sort of need right now to, you know, aim to replace estrogen. But I'll go on to explain sort of the different options. So in terms of like how we treat FHA, I like to sort of think of it as sort of three different areas. So what is your goal? Are you trying to achieve menstrual recovery? Are you trying to just replace estrogen, or is the patient wanting to get pregnant? Okay, so depending on what they want, that will sort of guide your further treatment options. Now, obviously, you know, the first priority should be to achieve menstrual recovery or regain menses, and that does involve a lot of lifestyle modifications, including weight gain. And you know, some studies have suggested that, you know, gaining weight of around 2 kilograms from what their weight was when they first lost their periods is useful. Obviously, if there is stresses involved, and actually this can be very subtle, because some women who deny any sort of obvious stress, it can actually be a collection of minor stresses that is probably more evident. And cognitive behavioral therapy can actually work, and you know, 88% of women can resume menses just following this. Some people have ended up using anti-anxiety or antidepressants to try and help that, and there are several experimental therapies that, you know, you can use, which is out of the scope of this lecture, but essentially they look at trying to stimulate the hypothalamus, so either using through leptin or kisspeptin. Now, in terms of replacing estrogen, you should really start to think about this when, you know, they have failed menstrual recovery. Okay, so because some women can go on for years and despite all of this still not regain menses, and you know, some studies have quoted usually between 6 to 12 sort of months is when you should start thinking about replacing estrogen if they haven't successfully had periods. Now, this sort of generic advice, there's no sort of ideal preparation, but the combined oral contraceptive pill is used if the patient wants contraception, okay, because this uses high doses of ethinyl estradiol and actually will not help with bone mineral density. Rather, using sort of transdermal estrogen with cyclical progesterone has been shown to actually help improve bone health. But hopefully Dr. Jay-Z maybe can help us later on in deciding like what doses, etc. Now, women who want to sort of achieve pregnancy, a good option is clomiphene citrate, which is typically used. However, for this, you actually have to have a certain level of estradiol. And in FHA, these women just typically have low levels, so it's not as efficacious. Some people use pulsatile GnRH therapy, especially in other countries, but right now there are sort of no pump devices that are available within the UK. And obviously the mainstay of treatment is gonadotropin-based therapies. However, again, there is a risk of what we call ovarian hyperstimulation syndrome, which is when you know, they get a high level of oocyte maturation and can cause you know, interstitial fluid accumulation, causing complications such as ascites, and you know, that ends up sort of people can end up in sort of ITU as a result. It's a very high risk. Okay, so this is our final clinical case. So here we have a lady who underwent menarche at the age of 9 and progressed through puberty normally. At the age of 24, she developed amenorrhea, lost 14 kilos in weight, BMI was 22.1, and she exercised 20 hours a week. And she, you know, in that she was, I think, an expert triathlon runner as well. And she also had stress that was related to work. At the age of 28, so 4 years later, she then came to see us in our research study, and we assessed her hormones. And again, she had hypoestrogenism with a reduced LH and preserved FSH. Then we called her actually back a year and a half later to actually get involved in one of our other studies. But interestingly, at the time, she reported having, you know, spotting probably 1 to 2 days per month, and they seem to be quite regular. At the time, her BMI had pretty much remained the same, and she was still exercising. However, she reported that her work stress had been relieved, and to our surprise, her repeat levels show that actually there is some sort of recovery. Okay, so although she may not be fully ovulating, she was showing signs of recovery. So this is our final question. So it said 1.5 years, but actually women can potentially, majority of them, achieve recovery within 2 to 3 months. And here is a sort of systematic review that was done by Papertal in 2021. And it was actually a very nice paper because they looked at all the different studies of women who either had eating disorders or who exercised excessively, and follow them up over different periods, so 12 months to 26 months, and essentially reported the percentage of women that actually recover their menses and how many months it took. Okay, and so if we look at the bottom here, so women who excessively exercise, i.e. the woman in our case who was doing 20 hours a week, actually within 3 months 68% can actually recover. However, interestingly, when you observe them over longer periods, so over 5 years, only 23% had recovered, which to me suggests that actually trying to maintain this sort of treatment change with nutrition supplement and reducing exercise intensity can actually be quite difficult to sustain in the long run. So they then looked at women with eating disorders in blue here, and again you can see that majority, around 68%, recovered their menses within 2 months after achieving normal weight and going through psychological therapy. And when you actually observe them over longer periods, about 80 to 100% can recover. However, it is important to still note that actually, despite all of these, interventions, 14% can still remain amenorrheic, and that's probably quite important to sort of highlight in your consultation, especially when a woman is struggling or getting more stressed at the fact that she's trying all these different things and still not recovering. Okay, so in summary, I thought that today we've kind of explained how FHA is a diagnosis of exclusion, how it can overlap with PCOS, and the primary treatment goal should be to recover menses, and in sort of eating disorders, weight loss, the papers sort of say restore weight, so this can be a 2 kg weight gain, achieve a BMI between 17.7 to 22.9, or a body fat percentage between 18 to 28%, and to also deliver psychotherapy. And in women who exercise excessively or who are athletic, trying to achieve a balanced diet, as well as limit training intensity and volume is important. But again, there is no sort of hard, fast rule as to how you should be managing these women, and it's very much based on an individual approach. Thank you. We have some questions in the chat, and I think Dr. Sam had his hand raised.
You can unmute, probably.
Hello, thank you, Bijal. Can you just clarify the point about estrogen replacement? So were you suggesting that you give combined oral contraceptive and Sandrina and Utrogestan for the bone?
No, so as far as my understanding is that when you use the combined oral contraceptive pill preparations, they have typically high ethanol estradiol, which is not known to actually improve bone mineral density. But
Yeah.
Dr. Jacin is here.
So can I say the confusion is, okay, there's someone who wants they've got osteoporosis, so you want to improve the bone health, and they also want to have contraception. In that scenario, do you think they should be taking an oral contraceptive pill for that purpose, plus Sandrina, plus Utrogestan for the osteoporosis?
I'm not sure.
Really good question. So I guess, you know, we have a reversible cause of infertility, don't we? We know that, so Bijal's absolutely right. So ethinyl estradiol is not estradiol. It does not pick up an estradiol assay. It's like nandrolone, okay? But it has a somewhat suboptimal protective effect, so it's better than nothing. And in my if it's important for your patient to have contraception, which and a minority will, then I would put them on the pill and not have them on. I think you'd be unduly risking cardiovascular events and thrombosis if you had them also on HRT, because you're double treating them. But so I would make an exception personally and put them on a contraceptive pill, knowing that you are making a slight sacrifice in bone density, but you are treating them somewhat. Now, others may have a different view on that.
Another option is some
Yeah. So if they would accept a Mirena, then that's fine. The problem with someone who has HA is that if they've had it from when they're young, their womb may be slightly small, and if we assume that they're a nullip, it may be very painful to actually insert a Mirena into a nullip hypogonadal uterus, and quite traumatic. Just to tell you that. Yeah, so no, that's a really good point. And obviously barrier contraception as well. And I think it's knowing the patient, but I think if they really sort of say this is a big priority for me, then yeah, that's what I would do. But it's difficult, isn't it? Because you are taking a hit in terms of their bone protection, and that is not the best thing.
I asked.
We can't see that. We can't see that. We can see dark light.
So, so a couple of questions. One I asked Chan already. In your first scenario, you have a patient who was on the pill. Is post-pill amenorrhea still a thing, or is this just an old-fashioned term that's been superseded for something else? The other thing is, what type of exercise causes, just for example, aerobic exercises that has a greater effect than anaerobic exercise with weightlifting on patients? The reason I ask is that I had a patient who was actually overweight. She was amenorrhea. She used to be a competition swimmer, but then gained a lot of weight, and then became amenorrhea, exercising by doing a lot of running. I got her to stop running, and slowly her periods returned. She's actually twins.
Yeah, no, so good question. So in terms of the last question about the sort of type of exercise,
just in case people didn't hear, so Bijal's going to ask about whether there are different types of exercise that affect amenorrhea differently.
Yeah, so women who typically have like resistance training and actually have more muscle and a more lean physique tend to actually, what we find, have amenorrhea, and that actually persists for a longer period versus exercises like cardiac related, because with that you're getting a reduction in weight but not necessarily body fat. And in terms of your first question about what was that again?
Post-pill
amenorrhea
just a default term?
So I mean, we, as far as I'm aware, we still sort of advise women that, you know, it can take up to 3 months once stopping the pill for your menses to return. And I guess that is just allowing for that sort of adequate wash-up period.
Yeah, I mean, I would agree. I mean, I think officially sort of after 6 months, by the time practically they've made it through a queue to see you in clinic, it's often been that time, and therefore I would not have that high up on your list if someone's had amenorrhea for 6 months or more, and it's impossible after a year. So I think that's often a get out clause that we use. I think we should be looking for causes of secondary amenorrhea. Other than that, yeah, we've got lots of questions up here. What happens to prolactin level in FHA?
So prolactin levels are usually in the sort of lower range of the reference range. And yeah, I think it's just mainly because these women are stressed, so you get suppression of other axes.
What about Mohsin Siddiqui? How does cognitive behavioral therapy help? Does it help to achieve sort of positive energy balance?
So that's interesting, because we've actually found some women who find exercising helps relieve their stress. And so when we tell them, can you stop exercising, they get more stressed, and actually using CBT in that context would help. So I think it can actually help sort of that behavioral component of things.
There's a nice small study by Sarah Berger. It's a small study, but they randomized people to CBT or observation, and they reported quite a high conversion rate in the CBT arm, and they gave bespoke CBT for 3 months. And I guess it's one of the few things people can actually self-refer to, but via IAPS. So yeah, it's something absolutely I think is worth always tackling. Is there a specific stressor like financial problems, and how? I guess they're asking, do we know much about specific stressors and amenorrhea and periods?
So what I have read is there's usually not just this one major stressor that contributes to their amenorrhea, and actually it's more likely multiple minor stresses, so related to work, lifestyle, and that actually accumulate, which then results in amenorrhea. And that's why actually identifying those and picking those out in your history can be quite difficult. But yeah, that's what I've sort of come across.
Interesting question from Uma. What is the minimum level of estrogen level required for? I think they've used the word ovulation induction. I wonder.
Endogenous.
Yeah, restart of periods maybe.
Yeah, and the easy answer to that is I don't know. Ideally, we'd love to know, because I think it will vary for each individual. So for example, with that last lady who I presented and we were showing recovery, we actually ended up doing a study on her, and her estrogen levels were around 500. So it's, I don't know, I don't know any sort of specific threshold.
I think in practice, I mean, that's an unusual case. I think once estradiol gets to 200, many women would start to ovulate, but it clearly, with your case, demonstrates that it's not everyone, isn't it? Yeah.
Was it return cycles? It's actual ovulation. She's been amenorrhea some time in her essentially will take several ovulating and having cycles before she actually has a need.
Can you repeat that question?
Yeah. So the question is the question from the floor was, maybe it takes a little bit of time if someone's had prolonged amenorrhea for the actual periods to return. I wonder, Bijal, whether, I'm sure you've looked into this, whether there are a proportion of people who have FHA and PCOS, and whether traditionally I would assume that 500 is quite normogonadal, unless they have a very odd SHBG. And whether they flipped from having FHA, a hypergonadal state, to an ovulatory state like PCOS, I don't know.
As in, so we've actually had a few of our participants who've ended up having unmasked PCOS. Yes. on recovery.
Yes.
But I tend to find those women tend to have higher androgen levels and AMH levels as well.
Yeah, very interesting. Thank you. Ali, Dr. Barr has given some very nice references. Thank you, Ali. What about long-term contraceptive pill-induced hypothalamic amenorrhea and time for recovery? I think we've kind of addressed that with sort of post-pill amenorrhea. So we would say an absolute limit is 6 months, but you really should, if they've been referred to you, be looking for obvious things, looking at thyroid function, looking at prolactin and looking for evidence of hypogonadism. And postpartum amenorrhea would be, it's normally been screened out by the GP. I've had GPs, like, say, for 2 years that someone might have postpartum amenorrhea, which is certainly way too long. Is there any data on access recovery in mental stress? So I think we've kind of partially dealt with it. Is there any specifics about different forms of stress?
So you can have sort of trauma related stress versus, you know, again, the sort of minor stresses or sort of general anxiety that people have. And usually it's the sort of general anxiety and minor stresses that actually take longer to recover from. And I think one of the main things is because it's just harder to identify them and therefore diagnose and treat those.
Yeah. Thank you. What's the chance of recovery from primary FHA? So this is where someone presumably has had primary amenorrhea with FHA. So typically these represent a more severe group of people because they may have presented in teendom with maybe anorexia. I've treated a couple of them. And the thing is that if you put them into a box and treated them like a lab animal and fed them and made them stop exercising, at some point, you know that you will get rid of the FHA. The big question is it acceptable to that person? And the chances are it probably isn't, without them something dramatic taking over their lives and a change. So I think people with primary FHA can recover, but often they don't because the treatment of recovery is unacceptable in terms of weight loss. People generally have quite stable weights because it goes with their identity and how they look and how they feel. And these, I think I don't know, forgive me if you didn't mention this, but some of these women do have heterozygous mutations in GnRH regulatory genes. So it may not be purely a environmental insult. There is a genetic component as well. So some of this may be something that they are born with as well. Oh yeah, so Artemis has made a very good point, which I forgot about, which is actually there are some types of contraceptive pills which actually are based on estradiol rather than ethinyl estradiol. So there's another one called there's Zoe and there's another brand name as well. The name escapes me. But yeah, so they actually are just using very high dose estradiol. So those would actually be predicted to be better for bone mineral density. So that's an excellent example if you can get hold of one. Thank you. Is there any FSH to LH ratio that would be helpful in determining FHA?
Not that I'm aware of. So, like I said earlier, the FSH is preserved compared to LH, and that's mainly because of the slow or deficient GnRH. I haven't actually come across any studies that looked at a ratio in women with FHA per se. I don't know if you've...
rather than diagnostic, I guess consistent, you typically get a lower LH than FSH. So typically you might expect an LH of 2 or 3, an FSH of 5 or 6, and an estradiol of 100. That's a very classic kind of patient. But, if you have an LH, a flipped ratio of an LH that's much higher than FSH, that suggests that the GnRH is quite high, and therefore it argues against someone being hypogonadal. Yeah, so the LH is generally lower than the FSH, as Bijal said. Is the reason why estrogens don't help with anorexia eating? Is there a reason why estrogens don't help with anorexia eating disorders, but do help with the female athlete triad?
I think Julian's online and can just unmute and tell you what he's asking.
Yeah.
So essentially, I believe the data for anorexia and eating disorders is even if you give them estrogens, it doesn't make a difference to their bones. But what you're saying is with athletes triad, it does. And I'm just wondering, is that simply a magnitude problem of the degree of energy deficit and the degree of secondary associated endocrine dysfunction?
Thanks, Julian. That's a great question. I think you're right. So clearly, when you've got sort of teenage girls who are sort of inpatients in an anorexic setting, then there are other things going on, and IGF-1. There are many other reasons why their and they got high cortisol as well, you know, why their bones, you know, they may have osteoporosis. And I guess we haven't had large enough studies to show that. I do think there has been a study from Boston showing efficacy in these specific groups, that you can have beneficial effects when you give transdermal estrogen. But I think it's a fact that you're talking about. So people with anorexia do have a severe form of FHA. So it's the same thing. So yeah, we absolutely would advocate a physiological approach and replacing estrogen. Yeah. Okay. Siva said, physiological changes happen at the hypothalamic level. Are we expecting any further treatment options around this? So I guess, do you want to allude to if you think there are any treatments around the corner?
Yeah, so good question. So some experimental therapies have looked at using leptin, because we know that there is a close link between metabolism and reproduction, and women with FHA are normally deficient in leptin. And I think studies looking at where they've given recombinant leptin as a twice daily preparation has actually shown recovery in menses, as well as improvement in reproductive hormone profiles. Another sort of promising therapy is Kisspeptin, which is the sort of research team that I'm working with. And, you know, we know that Kisspeptin potently stimulates the hypothalamus and the downstream reproductive axes. And actually, we've shown in HA women that, you know, giving Kisspeptin subcutaneously as injections can actually stimulate gonadotropin responses, and can also actually stimulate LH pulses. So that is sort of very promising sort of treatments that I'm aware of at the moment.
Thank you, Bijal. I think the £150,000 price tag on leptin makes it definitely not so slight. And obviously there's a minor non-significant weight loss from leptin as well in this group, which they didn't emphasize in the New England Journal paper, which certainly isn't a good idea in this group as well.
Yeah.
So we watched this space for Kisspeptin. I'll take the thing about is there a specific type of CBT? I think something is better than nothing, and anything that essentially helps people cope with the stresses of life is fine. We haven't had any bespoke kind of design about things, but essentially it is about coping mechanisms and controlling one's thoughts, and therefore controlling one's moods. But we don't have data about the specific type. Do you check AMH?
So in the research setting, I'm going to say yes, we do. However, I know now, especially with the new PCOS guidelines coming out, AMH is quite a feature in the criteria. So I think more and more people are going to be using AMH. However, in terms of like what cutoffs we use, that will be very dependent on, you know, the assays available in each sort of hospital. But I think, yeah, AMH is definitely going to come into routine use.
And apologies if you covered this, but if you take someone with HA and they recover, how much does that AMH change? Does it change? Do we know? Is there a bit of suppression when you're amenorrheic?
That is a good question. I think that they do have a level of suppression, and you know, when they do recover, they do increase, but I'm not sure exactly sort of how much that would.
Yeah. And yeah, so we've had a comment from Artemis, thank you. So having used AMH to sort of distinguish between lean PCOS and HA in a handful of patients, that's a good idea. The complication is, what if your patient has both?
Yeah.
And so let's say you've got, my approach from a clinician's perspective would be to say, always think about the gonadal state you have. If you have a person who has, you may have a woman who has acne and is shaving regularly, but are they hypogonadal right now? And you know, is their LH and FSH estrogen low? And if they're hypogonadal, they have HA. And if they're normogonadal, they have PCOS. But women have the ability to have, so you've got to decide which is the dominant diagnosis. And so the issue with AMH in these women is that it doesn't help you distinguish right now what their state is. So I think if someone's got an AMH of 50, then that tells you they have the ability to have PCOS if they're normogonadal. But if they then starve and are stressed, they may have an AMH of 50 and have FHA temporarily. So the FHA almost caps off and is higher up, can shut off the ability of their PCOS. In my simple way, that's how I think about it. Yeah.
So would you then tell these women to
That when we cure them,
yeah,
to expect that they have PCOS,
yeah,
but then to counsel them that PCOS comes with very good fertility potential, and it's not all bad as well. Yeah. Thank you very much, Bijal. That was amazing.
Thank you.
Anna,
Thanks.
can I ask one last question related to part of the question asked before? So we look at BMI weight. Should we be looking at body fat percentage? Is there a threshold at which point you can attract to stuff?
I'll put that to Bijal in case you've seen anything on that.
So what I've been reading around.
So the question is body fat percentage a useful marker to be thinking about in addition to things like BMI?
So it is useful, and studies have shown that I think body fat between 18 to 27% increase can enable you to recover menses. But I'm not sure how pragmatic it is to actually do in clinic on a routine basis.
Yeah. I'll tell you. I'll tell you what. I'll tell you what I do. Knowing the type of patients you have, I say next time you're at the gym, get on one of those things, or I'll say, "What's your body fat percentage?" and they'll often know. And
there's an app for it.
Yeah, think it's as a middle-aged man who wants to keep his weight down. I know that basically, if your body fat percentage is above 20, well, that's a bit high. But often the warning signs are if their body fat percentage is 10 or below. And something like 15%, this is completely in the absence of evidence, and it'd be nice to generate evidence. 15% is quite average.
So is that quite being started to do? People know their body fat.
Yeah.
It's not been studied. Someone must have studied.
No, but it hasn't been. I mean, yeah. I mean, there are varying degrees of accuracy on there. Yeah. But anything that can help. These are data-driven. These are intelligent, bright women, right? And so anything that helps them to monitor or track themselves. Now, one could argue that maybe tracking stuff is a bad thing. It causes more stress. But I sometimes ask them about that. So it's a really good point.
And is it the same? Your other tool for men with their body fat percentage and men?
So yes, they're probably not going to go. They're probably much less likely to know their body fat percentage for lifestyle reasons. But yes, so we have this challenging thing of obviously obesity-related infertility and hypergamy as well. So you're right. Fantastic. Thank you very much.
Thank you.
Thank you, everybody. Can you please click on? I'll put a link in the chat to make it easier. Or click on the QR code. And our next thing happens on the 18th of September. That's the appreciation meeting. So do it for that if we haven't already. Thank you very much, all. Stop yet. Okay.
Thank you. I'll send a QR code.
There's a Financial Times article about the marketization. So they will know their body fat percentage because that gives you growth technique.
Great, thanks everyone. I'll just pause